So good morning, everybody. Thank you all for joining us today. Welcome to the 2025 Empowering Health, Advancing Access, Inclusion, and Integrity Through Emerging Technologies Conference. My name is Nerys Millette-Williams. I'm the Digital Literacy Project Coordinator for Marylanders Online, and I have the pleasure of being your MC for today's conference. This event is brought to you by the University of Maryland Extension Marylanders Online in partnership with the College of Information and Collaboration with our Family and Consumer Science Department under the extension. We have a great lineup planned for you all, and we're very glad that you guys are here to be a part of it. So before we get started, I wanted to state that all university programs, activities, and facilities are available to all without regard to race, color, sex, gender identity or expression, sexual orientation, marital status, age, national origin, political affiliation, physical or mental disability, religion, protected veteran status, genetic information, personal appearance, or any other legally protected class. Additionally, before our opening remarks, please see the following slides that includes QR codes for our speakers and planning committee, completing our conference surveys, and registering for our webinar series. You can also find these QR codes on our website or on the program agenda that you guys received by email. So to begin our program, please join me in welcoming our opening speaker, Dr. Jinhee Kim. Dr. Kim is a professor in the Department of Family Science with the School of Public Health at the University of Maryland. She also serves as an assistant director and program leader in Family and Consumer Sciences with the University of Maryland Extension, part of the College of Agriculture and Natural Resources. Dr. Kim's work focuses on critical intersections between financial management, family well-being, and health outcomes. Her research and leadership has made a lasting impact on communities across Maryland. Over the past 3 years, she has fearlessly led the University of Maryland Extension, championing innovative programs and initiatives that empower individuals and families to thrive. It's an honor to have her here with us, so please welcome Dr. Jinhee Kim.
Thank you, Nerys. Good morning, everyone. I'm Jinhee Kim, Associate Dean and Associate Director for University of Maryland Extension, part of College of Agriculture and Natural Resources. I'm so excited to meet all of you virtually, and I heard we have over 200 people registered for this exciting event. And this is a emerging, inspiring event. If you are passionate about health and technology, or better connect with those who deeply care about this topic, you are in the right place. Today's event is brought to you by Marylanders Online, a project of the University of Maryland Extension in partnership with the University of Maryland's College of Information Studies. And also, this is a special program of the Family and Consumer Sciences program of the UME, University of Maryland Extension. This gathering is a result of an incredible collaboration among people and organizations who care about real, positive, impactful changes. The idea of this conference, Health and Technology from a Shared Vision, what if we can bring people together to explore how technology and health can work hand in hand to empower communities, build digital success, and create healthier and more connected lives for Marylanders and beyond. Today's session will highlight some of the most relevant, exciting events in this space, but this is just the beginning. We are already planning a series of webinars to keep this momentum going and dive even deeper into these important conversations through webinars. I want to share my special thanks to Planning Committee, the Project Director, Isaias Tesfalidet, Nerys Millette-Williams, Carrie Grant, Alex Chen, Drudy Patel, and Lynn Mateva, and special thanks to Julie Slipka for smooth coordination and running of this event. So let's get started. Get curious, get connected, and most importantly, let's have some fun. And thank you everyone for joining us today.
Thank you so much for that, Dr. Kim. That was a very thoughtful and empowering welcome. Please note that you can find the bios for all speakers by scanning the QR code in the bottom right corner that you can see here. We are very excited to get started with our presentations today. We'll be covering a range of topics, including health misinformation, artificial intelligence, strategies for reaching diverse populations, as well as a panel discussion on key issues at the intersection of health and technology. We'll also have a keynote presentation focused on access as care at the end of the day. As we move through today's in-service, please feel free to ask questions using the chat or QA function, and engage with speakers and presentations using the reaction function on Zoom. Also, feel free to turn on captions, and Zoom also allows transcriptions to be translated into different languages. Additionally, if you can, we ask everyone to please turn on your cameras. So our next speaker will be Dr. Galina Reitz, who will be teaching us how to ensure fairness in health technology through AI, accessibility, and bias. Dr. Galina Reitz is the Faculty Program Director in the College of Information Studies at the University of Maryland, College Park. She holds a Ph.D. in Information Systems and a Master's in Management of Aging. Prior to joining UMD, she spent 12 years at UMBC as a faculty member and administrator, where she helped grow enrollment, launch strategic initiatives, and diversified course offerings. She has collaborated with companies to design technologies for older adults and has presented her research nationally and internationally. Her work spans topics such as voice technology for individuals with cognitive impairments, person-centered technology development, quality of life enhancement, and home-based tech solutions to support caregivers and care recipients after cognitive decline. So thank you all for joining again, and please join me in welcoming Dr. Reitz.
Thank you so much. Good to see you, everybody. I'm going to go ahead and, oh, I guess I can't share just yet. Oh, yes, I can. There we go. As a technology person, I always worried that the technology will fail me. And I'm gonna go ahead and, oh, let me start the presentation and hopefully everybody can see this. Thank you so much for the wonderful introduction. Dr. Doo will be hard to follow. That was so insightful and very cool. I will take us in a bit of a different direction. And I just wanted to kind of give you a little bit of a background of where my presentation is coming from. And like I said, it will not be as cool, but hopefully, we together can kind of go on a journey about thinking about AI accessibility and really kind of how we can utilize, whether it's voice assistants, ChatGPT, or any other kind of device and tool to really support our personal healthcare needs. And so I'm really excited to kind of frame this presentation from the perspective of human-centeredness. And as Nerys mentioned, a lot of my work is with older adults, with individuals who have cognitive impairment, particularly dementia. So my perspective on research, on practice, and how I approach AI is really from the perspective of we need to support the human. The person is in the center of the technology. And if it's not useful, if it's obtrusive, then it really doesn't make the cut. And so for the last, I would say 15 years, I have been working very closely with voice assistants. So the Googles, the Alexa, if you have one at home, I apologize. She may start talking to you. But voice agents I found particularly helpful as an AI tool in supporting the population that I work closely with, which is caregivers, care partners, older individuals. And so I will talk a little bit about that. But as we are kind of exploring this new world of AI, and I know that our audience is quite diverse. And so I know we have academics, but also individuals at home. We have providers. I try to kind of make it as broad as possible, but of course, happy to talk offline and have more conversations. So today I'm really interested in thinking about how can we utilize these really cool tools in order to support accessibility for all. And I know that we may identify with a particular group or population, but I firmly believe that really technology should be supporting every individual. And so that's my particular perspective. And I live within the College of Information, and really our mission is to support individuals through data, but ultimately to do good and do some social good in the world. And so bias and ethics is something that I'm also passionate about. That line of how much data you're sharing is really fine in terms of kind of what you're giving and what you're getting back. So those are the conversations that I always really enjoy having with colleagues and students and others, and how we can approach AI in an interesting way where it supports us, but also doesn't necessarily share every single part of us, including our data. So I mentioned some of the assistive tools that I utilize in my research and practice, which is voice. My mission with voice technology and with enhancing accessibility with AI is to simplify it as much as I can, put it in everyone's hand, and then if it works, wonderful, but if it doesn't, that's okay too. And for us to think about what are ways to kind of modify and personalize these tools that are readily available on the market. So, 15 years ago when I started working with Alexa, it was quite expensive. It was not easily accessible for $19.99 off of, the Amazon store. And so there were lots of barriers. And that's something that I really fought with Amazon. And especially when I was doing a lot of research and needing to kind of buy those tools and place them in older adults' homes to see how they can support them. So I think removing a lot of these assistive technology barriers is really, really key. So we do this at UMD in many aspects, which is really great. But ultimately, I am very passionate about consumer technology, being able to access something that's easily available and then modify it in your own home and figure out ways to support yourself or somebody that you care for. So lots of cool things that we do at our college in particular, such as, we do a lot of work with blind users, with screen readers. We're really trying to teach our students to think about accessibility, to do good in the world, and to kind of recreate and redesign these systems that are now maybe outdated and do not support those who are most in need. So voice interfaces are wonderful. I always encourage those of you who maybe don't have a lot of experience with Alexa or Google Home to just grab one and play around with it. There's lots of accessibility tools now built in, which is wonderful, but also it's really, easy to use for everyone and really helpful, whether you're, a working professional, somebody who's retired, a child, right? It's an interesting technology that really supports a lot of individuals. The other assistive and accessibility tools that really AI has revolutionized is translation and real-time language translation. And in healthcare, I'm very close to this because my dad is a physician and we speak a very particular language that's not often common. And so for many, many years, he volunteered as a translator for young children or individuals who needed to, be able to share their healthcare concerns with a healthcare professional, but couldn't in English. So my dad was a medical translator, and he loved the work and really enjoyed it. But that's not sustainable, right? There's so many different languages. And so now we're seeing these incredible ways to just speak and speech to text. And, I wish I had that when I was collecting data back in the day for transcription. Everything had to be, you had to listen and then type it out. And that still happens, but I think it's really exciting where we're going with AI and translation tools. Wearables are everywhere. I just saw a talk on someone who discussed, data collection of the self and this kind of like self ethnography, which is a really interesting concept. I think all of us do it, right? Whether we have an Aura or an Apple Watch or just your phone that's collecting, health and biometric data. I think it's really incredible how we can now make decisions based on these available tools and really take control of our own data. I think that's critically important. One of the barriers that I saw a lot in healthcare, and especially the work that I did with senior care communities, is that the person who we're caring for really didn't get to have access to their data or to kind of the information that was being recorded about them. So things have really changed, and I really appreciate that. So I'll talk about how now we have more control, but also with tools like ChatGPT, now we can really have that information translated into a language that we can understand that's not medical speak. So that was a huge barrier. So I think that's really exciting and really empowers all of us, I think, to make decisions for our health. Screen readers, voice assistants, all of these tools really enhance communication, especially, as I mentioned, with the population I work with, where sometimes and often they are not given a voice. And so having interactions can be really meaningful. So I really encourage you to kind of explore voice assistants, but lots of other interesting robotic tools that are on the market that all kind of fall under the umbrella of accessibility. We're seeing a lot more chatbots. Back in the day, I was working with more kind of robotic toys, if you will. If you remember, there was a little seal that used to be very popular in Japan. We brought it to the United States, and we figured out that culturally it didn't make a lot of sense. And so there's lots of interesting things to discover when it comes to robotics and accessibility. So these tools are, I think, ever evolving, and like I said, consumer technology can be very powerful. And so whether you're looking to support your aging parent with Alexa Together, where you can kind of keep in touch with them and make sure they're okay and they're getting up in the morning and making their coffee and you're getting notifications. There's lots of ways to increase that communication, provide companionship. And a lot of the elders that I work with are often living alone and don't have a lot of support. So by no means will the technology replace the human, but I think it can really enhance some of our experiences. So like I said, my slides are not revolutionary. It's more of bringing this kind of conversation to the surface and thinking about how we can bring these tools into our home, into our work. And I have to say, I did a presentation on AI and enhancing kind of the experience of providers in senior living facilities. And out of a full room of exceptionally smart people who care for older adults in various capacities, when I asked how many are utilizing ChatGPT in their work or in their life as a tool to gain feedback and get ideas and kind of interact, there were very, very few who utilized it. So I am more immersed in academia, so I can see that the kind of why we have apprehension in utilizing some of these tools, whether it's ethics and bias, but I'm really interested to know kind of what are the barriers and how can we minimize those barriers so that way we can, really get the most out of these tools. So I am very much a power user of chat, of voice assistants, of wearables. And so I'm trying to kind of, make us think about how can we minimize some of those barriers and bring those tools in order to support our life and our experience. So other than translation tools, I think those can be very powerful. And I mentioned this a lot because in healthcare in particular, now, we have a lot of providers with a lot of diverse backgrounds, a lot of patients with diverse backgrounds. And so having a pocket translator in your, in your backpack of tools is so critical to be able to make really great decisions, to be able to establish a relationship with somebody who may not clearly understand you. My parents both still have very, very thick accents, and it's very interesting to see how the tools have really changed since I first installed an Alexa in their home 10 years ago and now, and how, because they're continuing to interact with that tool, it has really built an understanding and knows when they're saying certain words and can comprehend and then give them an appropriate answer. So the ethical part of this, and I think the bias that we see, is some of us who are part of a particularly vulnerable population may be apprehensive to use these tools. But I have to say, these are the individuals who are the most important to give data and to give feedback in order for these large language models to learn and to get better. So it's very much a double-edged sword. I said this in the beginning. We're providing a lot of our data in all aspects of our life, from the moment we wake up to the moment we go to bed. Somebody's collecting information about us. And I think unless we're moving to the outskirts of the United States with a tin hat foil, we can't avoid giving our data to some entity or to some company. So I think about that a lot, and I worry, but also really I think often the benefits outweigh the risks. So this is something that you can make a decision for yourself. But in terms of patient care software, like I said, there's so much biometric data that can be very insightful, and not only to provide information to your physician or provider, but really, like I said, for you to take control over your own data and to really have a better understanding of, well, I'm seeing changes in this particular let's say heart rate, or now we're having keystroke software. I'm seeing some changes and I'm monitoring myself. And so what insight does that give me before you see your physician? And then you can really kind of come to them with some data and make informed decisions together. So there's lots of, I think, avenues where we can bring technology and human and have this, really great experience. Now, does it always work? Absolutely not. Should we be relying on this technology wholeheartedly? I personally can't. I can't really, give up all of that control. And so, we all kind of have to make those decisions and what makes the most sense for each of us. A lot of these tools. Oh, yes, Nerys.
I'm just wanted to point out there's a question for you in the chat here.
Oh, sure. I'm sorry. I am full screen.
The question is, will robotic toys create an insensitivity to real pets? For instance, if a child can dismantle a robotic dog, are they more apt to harm a real puppy?
Wow, what a deep question for 10 o'clock in the morning. Oh my gosh. That's a great question. I don't work with children. As I said, I'm on the other side of the lifespan. But I have to say it really depends. I think there's lots of factors. And I can speak from personal experience with my children who have robots in the house. And I have to say, unless there's, kind of deeper trauma or tendency, and, I think caring for something can be really helpful. So, I see the way that my children interact with kind of their little robots and with Google Home, and they've built a relationship. And I saw this also with the seniors I worked with. So do I think that can happen in some cases where, you lose that sensitivity? Absolutely. Do I think it happens on a larger scale? I don't think so. I think if we're really kind of putting the right tools in the hands of, anybody, and kind of monitoring the interactions and making sure that they're valuable, I think those can have a great outcome. But very, very deep question. And I hope I had a better answer. But like I said, when we had the seal, when we worked with the pet seal that really worked for older adults in Japan, they built a very close relationship with the robot. We didn't see this in the United States, and I think because we just have different culture, we think about sort of interacting with this kind of robot in a different way. I'm not going to talk too much about this, but I definitely saw that with the seniors that I worked with and the interactions they had with Alexa. Some built incredible relationships with the tool. They would call her their girlfriend, their friend. They were excited to talk to her every day, and others would just put her to the side and say, I would say, I don't want to talk to a robot. And she would collect dust, which was, for me, of course, important to understand. So this is why I like the idea of customization. Not, it's not an all, one tool is not going to fit all of us. And so I really appreciate kind of the customizable abilities of a lot of these tools. And so, you know, I used to be a very, very much of a power user of an Apple Watch and really appreciated the insights and the data. And then ultimately just went back to analog. I think I needed to be released of that obligation to complete circles and to, I had data fatigue. So that can happen as well. But that doesn't mean that, we shouldn't have insight of our own data. And I'll just kind of give you a personal anecdote. I have to see a physician on a regular basis, and there's lots of blood work that I need to get done. And now we have access to my chart. So of course I would download, my blood work and my labs. I have no knowledge or understanding of how to interpret any of that. So back in the day, what I would do is immediately send the PDF to my mom, who's a physician, and, she would come back and say, oh, this looks normal, but this is a little bit high or this is a little bit low. Well, as of late, I have just been throwing it into ChatGPT and saying, please give me an idea of where my labs are. I think she feels she feels excluded now, so I still send it to her. But I feel very much empowered to kind of have an understanding of what these numbers mean without, necessarily having to wait for a phone call from my physician or talking to my parents. So I went off on a tangent, but a lot of these AI powered wearables can be very insightful. I think they can really empower the way we interact with our providers, the data that we come to them with, and I think it's really great for disease management. So whether you have if you're sleeping with a particular tool and you have insights on how well you sleep, that can change behavior. So a lot of these tools really are there to help you kind of make very tiny but maybe substantial down the road changes. And like I said, I'm not disillusioned where I think this is going to work for everybody. I really don't. And so, you being able to download an app and customize it to your own needs is really important. So, whatever you're tracking that's meaningful to you is important. Having some predictive analytics, especially for those of us who suffer from chronic diseases and really have to manage our health, and the numbers really matter, and those numbers have to be stored somewhere and then shared. I think AI tools can be very powerful. We're empowering ourselves more and patients through these data insights, and so we're not going in blind. And, I grew up in a family of physicians. And so, I by no means do not respect or think the inside of a physician is important, but it's also great to have some understanding for yourself and do some research and come with questions, and really be able to have a conversation. So I'm very excited about the future of these tools. And of course, with a lot of this information, and in our college, we're very focused on data science and really empowering decision making through data. There comes a point where there is bias, there are concerns. I don't think, we should go in this blindly and sort of surrender every single piece of information about ourselves. We should be critical about what's being shared. When ChatGPT first came out, and we were having conversations with colleagues on the UMD campus, it was really interesting, the perspective of different faculty members and how they were going to utilize the tool with their students. Some were worried about, inputting student data into chat, having that be open to the world. Others were very excited and early adopters. And I really see this with my partners in aging services. I think there's a spectrum of use when it comes to these large language models and feeding them information and getting feedback. So this is not a great way to look at this, but it really depends on kind of which industry you're part of, or which sector of healthcare. For me personally, as a researcher and a teacher, I'm very careful what type of information I input. The great thing about UMD is that we're very much ahead of the curve, and we have developed our own TERP AI, which is wonderful. Students and faculty and staff and everyone on campus can utilize it, which is really exciting. And it's a closed system, so it doesn't go out into the world. That's very exciting. But these models are basically fed on what we kind of input. And so there's many examples where we've seen bias, right? We all have bias about something. The way we talk to chat is different, and that's how it interprets its relationship with us. Yesterday, I typed into ChatGPT, "What do you know about me?" And it was quite frightening about, looking at sort of everything that I've inputted consciously or subconsciously, and then, chat feeding it back to me. So bias really arises, and I saw this a lot with Alexa because I used to collect a lot of Alexa input from individuals and look at kind of what types of words were being used, the interactions. And so it really depends on the training data. And so we in research and in academia have to be very careful about making sure that these models are being fed appropriate information. But bias arises when these models are trained, and especially for underrepresented groups. And so those of us who have access to the internet are power users. I have a lot of interaction with individuals who don't have access to the internet. And I know to some of us that sounds, completely bizarre, but it's the truth. There are individuals who have to walk to a library in order to connect to the internet. And so I think we live in a little bit of an AI bubble, but I think the human part of that is we have to recognize that there's lots of disparities in treatment recommendations. And this is something that we're not going to solve today or maybe in the next couple of years. But I think just kind of being conscious of this algorithmic bias in healthcare in particular is really important. I have to say these diagnostic tools are becoming more and more sophisticated, but I am seeing a barrier to use. And so we do see some individuals who are not as comfortable in utilizing these tools. I just had an experience at a doctor's office where you had the ability to choose for your clinician, obviously, to give you information about your results. It was a scan, and you could always, and you were given the option to pay extra and have an AI tool give you a second opinion. I chose it because I was just really interested to see, what is the difference between a real human and an AI agent giving me information back on my scan. But there was an elderly woman who was next to me, and she had to make the same choice and chose not to. I mean, I wasn't that annoying researcher who went after her and started asking her questions as to why she didn't choose to go down that road and get some AI insight, whether it was because it was an extra cost or there was no interest. But those are the questions that I'm really interested in exploring, and how can we bridge that gap? So this could be equitable. These tools can be equitable for all. We see ethical risks when we're reinforcing systemic inequality with these tools, and building patient trust is really, really key. But once again, humans are flawed, and so we're feeding oftentimes flawed information into these algorithms, which is not our fault, but it's something that we need to think about and consider. So not to kind of throw too much examples at you, but I did want to kind of bring this to your attention. Some of the bias that we see with AI, I think the most popular example is with the pulse oximeter for, when it was being utilized a lot during COVID. And we, providers started to realize that there was a lower accuracy for individuals with darker skin tones, and it was not something that we had considered before. And so it was providing wrong information, and that data was being fed into tools and then analyzed and perpetuated. So lots of bias coming from kind of that aspect. We see now physicians more and more utilizing natural language processing tools, so voice to text. It's exceptionally easy to use. Physicians are busy. Not everybody has transcription services, but we are seeing sometimes misinterpreted gendered language, misinterpreted African American vernacular English. And so this is something we need to think about and consider and not fully rely on these tools. Some other examples, as I mentioned, with the imaging, AI can be wonderful in giving some insights based on an X-ray or an ultrasound, but I really firmly believe that we cannot exclude the human factor. And so absolutely, will it be important for you to take your X-rays, download them, plug them into ChatGPT and have some insight? Yes. Should you fully rely on those insights? Absolutely not. So I think it's really important to be conscious of this bias, understand it, ask good questions, but also, like I said, this is something that will take time to iron out a lot of these kinks. So some other examples that we see in healthcare. So what are the strategies for fair AI? As I said, I'm a pretty practical person, so I don't think we can solve this easily, but I think those of us who are in academia, who are doing research, we're very focused on making sure that we are really combining diverse representative training data into these models. I really appreciated the work. By no means is this plug for Amazon, but the work that they did with me when I was looking at caregivers and care recipients and making sure that we understand what the needs are of older adults, especially those with cognitive impairment, and how we can support those needs. Carrie, yes.
Yeah, we have a question in the chat from Tracy. She wanted to know what the cost of the AI second opinion was.
Great question. I think it was like $29.99, for the budget price of $29.99. Yes. So it wasn't a tremendous amount extra, which is why I kind of opted in. And it was really interesting. And I have to say, my physicians, how they give you kind of a write-up of what your scan results. It was my physician wrote 2 sentences, and AI gave me this full report with very detailed information. So it was good to kind of have both of those. And like I said, I am interested in that, so I kind of tried to early adopt and look at that, but by no means was I going to rely on the agent. So if I had been given a choice between a human and the AI tool, I would have definitely opted for a radiologist. But it was cool to see both of those results. Thank you for the question. So as I mentioned, now that these tools are coming on the market, I think it's important to be transparent. And I think there's kind of some mystery around these AI models. We use abbreviations, and in academia we try to be fancy about things. But I have to say, like I said, to me, my perspective is, if it's not helping the individual, then I'm really not there for it. Whether it's a cool, new, shiny thing that's on the market. And this really kind of bleeds into the work that I do. I'm currently working with a physical therapy startup, and they've created a really cool AI agent that helps individuals who have to do physical therapy at home. So that's something that I see real opportunity for development and results. That's something that has an impact on the individual, that's low cost because you can plug it into your phone. And you can do it at home with a chair. So to me, really, that's kind of the technology I look at that I think can be really impactful. So I will be collecting data from a diverse group of individuals, which kind of feeds into my strategy for fair AI. The way that I teach my students, whether they're undergraduate or graduate students, we think about inclusive, human-centered design practices throughout their career in college. And so we're hoping that we're graduating these individuals who are very focused on person-centeredness, on strengths-based, on the idea that we're here to do good for humanity, and the technology is really a tool to support us versus, relinquishing all of our data and information to these robots and hoping for the best. So, and I think building data sets that really represent a population. For a long time, we did research on, individuals that we had access to, and that's not always the best approach. So I'm very conscious in working with diverse group of individuals, and a lot of my colleagues are as well. So that's an exciting new avenue. So these human-in-the-loop systems are critical, as I mentioned with my scan. The clinician AI collaboration, I think, is key. We really want to be able to assist practitioners. We as individuals want to assist our physician with the knowledge that we have gained from these tools, and be able to make impactful decisions. And so never eliminating the human oversight, allowing human oversight to catch errors, I think is really important. Also, these tools are very powerful, not only in kind of the traditional healthcare space, but when you're thinking about your own interaction with your tools, there's reminders that you have set for yourself, right? So we have to be conscious of kind of mitigating some of that alert fatigue, right? And that's the best part of customization, is that, I can set reminders for medication as many times a day as I need. Those individuals that I worked with who cared for somebody with dementia found a lot of these voice assistants very powerful and very helpful, because you could really personalize the alerts or the experience to the needs of yourself or the person you're caring for. And so there's lots of more research and work that needs to be done, but it's exciting. And the unfortunate part and kind of the ethical considerations is that, like I said, we have to feel comfortable to give up our data and to share in order to build stronger, smarter systems. So it is a little bit of a double-edged sword. And I think about kind of the opportunity cost. How much data am I giving up? And what am I getting, back in return? And I have to say, at this point, I've given up a little bit, because technology is all around us, and I'm really trying to kind of figure out what are the best ways to support me, my family, those that I care for, and those that I work with. And so to me, the kind of the human in the loop is really critical, and that's how I think about all of the work that I do. I'm not gonna talk about too much about policy and regulation. It's not my area of expertise, but I do talk about this in my ethics courses and ethics and big data courses with my students. And some of the regulations that we're seeing, of course, HIPAA is something that we're all aware of. But now with these AI ML models and software and medical devices, we are seeing some more FDA regulation, which I think is absolutely needed. Where, NIH is spearheading a lot of this AI research. And so it's really kind of exciting to see where it will go, but also make sure that we're not living in the AI wild west, which I think often happens, because I absolutely can feed my lab results into ChatGPT, make decisions, and act on those decisions and behaviors, and make mistakes about my own health. So there's not a lot of regulation when it comes to, healthcare and AI. So I am interested to see where this goes. How do we handle this? And, ultimately, how do we ensure that bias is minimized, and we are thinking about the ethical considerations? So in development, we are seeing the Algorithmic Accountability Act. It's proposed. It would require companies to audit high-risk AI systems for both bias and effectiveness. We're seeing FTC being more conscious and scrutinizing some of the AI tools, health tools in particular, and especially these tools can be very, very deceptive. I used to do a lot of kind of talks around the area about elder abuse, especially we're seeing lots of scams online. These scams are so sophisticated now, and they really cover all aspects of our life, whether it's you're getting a phone call and it sounds exactly like your grandchild asking you for money, to sending you text messages that seem like they're coming from your physician or provider. These scams are so sophisticated, so I think we really need a lot of oversight. But ultimately, I have to say we kind of have to make sure that we're conscious of the information that we're receiving, and making sure that we're very, very conscious of what we're clicking, what we're installing, how we're approaching a lot of these tools. And I say this to the seniors that I work with, but really for anyone, you should have kind of a designated partner in a lot of these interactions. Somebody who you can send a screenshot and say, is this legitimate? And it has happened to people in my family, people that I work with, where they have been deceived. And like I said, these AI agents are so realistic that, not to kind of fear monger, but it's something that we really need to be conscious of. And a lot of the population I work with is part of the disability community. And so for me, it's really critical to think about how do we make these tools accessible, but also safe. So that's something that I'm very passionate about. I'm pretty sure the last speaker talked about DXGPT, so I will not repeat the information, but I am very excited about the idea of more personalization and customization when it comes to taking control of our data and these tools. As I mentioned, the company that I'm working with that has developed the physical therapy agent, it's very exciting because it tracks your motion and then can give you feedback of whether you're performing your physical therapy exercises well. So these tools that are being built for good are really exciting. And like I said, taking control of our own approach to healthcare is really critical. And I don't want to fearmonger. I am very much of a power user of chat and other AI tools. So I think if you haven't, depending on kind of where you are in your tech journey, if you haven't played around with these tools, I really encourage you to do so. It can be low stakes. It doesn't have to be, necessarily healthcare information, but something about reframing a particular situation in your life. I have to say, this sounds silly, but ChatGPT is giving me a lot of pep talks. Sometimes, I'm sitting at my computer and kind of an irrational thought is coming to mind, and I'll just plug it in. And now there's, lots of kind of funny things on social media about how we're building this relationship with our AI tools, but it's true. And I think if you're aware of that interaction and you control the data, it can be very, very powerful and insightful. So chat has definitely helped me reframe some things, but also, sometimes I'll throw in my Aura Ring data into it and get some insights. Ultimately, does it change my behavior a lot? Maybe in a small amount, but still, I think it's cool to kind of see what the feedback you get. So I just kind of across the board say use these tools for convenience, and just kind of make sure that there's the human factor involved. And so I am excited about the future. I think there's lots of interesting ways that we can connect wearables to these AI tools, to our home ecosystem. For a long time, when I was working with Alexa and older adults, I installed the particular devices, the speakers, but also hooked them up to smart lights and other tools around the home. So I really appreciate the idea that you can really customize your home, make it a smart home, and then kind of create this full network of technology. But ultimately having the most control. So it is really exciting. And I think it helps, as I mentioned, with accessibility, but also accessibility is good for everybody. And so whether it's online in our home, I think the future is really exciting. So like I said, kind of taking control of our own data is really important to me. And like I said, you know, this is not the most revolutionary talk that you'll hear today, but I wanted to kind of get you thinking about, you know, what are ways that we can increase accessibility in healthcare, and from wherever we are, whether we're in industry, in academia, really whatever walk in life we are. I think it's really important to think about how can AI enhance our interactions with our healthcare providers, and thinking about bias and proactively addressing that. And so if you are part of a group that's marginalized or doesn't necessarily is involved in a lot of research and feedback, I really would encourage you to provide that data. And I know that it can be difficult, but this is how we combat this this bias and really think about the ethical considerations. And for us in academia and those of us in research, equity is critically important. We do this in our research, but in our teaching as well. The way that we design, the way that we interpret data, the way that we think about policy and informing policy decisions. So I think it's really important to teach the next generation to care. And so that's my perspective with my students. And you know, the future of AI is really exciting. I think enhancing access, enhancing control to those of us who want to take control of our data, but also giving insight to our clinicians and really supporting their very, very difficult lives as practitioners can be really helpful. And so I really encourage you to utilize ChatGPT, kind of start from anywhere, whether it's a question or insight or a recipe or intrusive thought, or if you need a pep talk, I really encourage you to utilize it. And after I gave my talk to the aging services community, I did have some feedback from those who participated and said, I did start using it and it is very cool. So even if it's one person, I think it's wonderful. And by no means am I pressuring you to use it, but it can be very, very helpful in making decisions. So that's kind of the takeaway that I have. And you know, that clinician in the loop is really important. Now physicians more than ever have you know, less and less time with us in the doctor's office. Sometimes you see your physician for 5 minutes, sometimes for 30 seconds. And so it's hard to build rapport. It's hard to tell your life story to somebody who's seeing you for 5 to 10 minutes. And so I am interested in seeing how can these AI tools really provide a full picture, a holistic picture of us as individuals to those that work in healthcare and can really understand us. I see this a lot with, you know, those 80 and 90-year-olds that I work with, that is a full life history. And so how is it documented? How do you know that, yes, Mrs. Smith has this chronic illness, but you also should know that she exercises 5 times a week, goes to see her grandkids, you know, twice a month across the country. Those are really important factors that can influence medical decisions. And so I really feel very passionately about a holistic picture. So that's kind of my perspective. And, you know, I'd love to open it up for a conversation with you all, just kind of having you think about, I would love to hear what are the challenges that you're seeing with AI? Are you using AI in your work, in your community, in your industry? How do you use chat with your own personal health journey? So those are the things that I'm interested in hearing about. And so I wanted to leave some time to have a conversation with you all and just stop jibber jabbering and hear from you all. Thank you so much.
Thank you so much for that, Dr. Reeds. We want to go ahead and open up the floor to questions. You can go ahead and use the chat or you can raise your hand.
Thank you, Chris. That's absolutely wonderful. I have used Claude and other platforms as well. I have to say, I kind of keep going back to chat, but absolutely, you should explore all other models as well.
And we did get a request for recommendations for AI translation that interfaces with EMR from Casey. I'm not sure if you know.
That's a great question. So EMRs are a little bit of a difficult animal. I have to say there's quite a lack of interoperability when it comes to EMRs. I don't think I can answer your question right now, but please email me and I will figure out a solution. But that's a hard one.
This is Casey. So I work for Massachusetts League of Community Health Centers. So I'm part of a health center control network. I'm not expecting an answer today, just saying if anybody had any feedback. It's a super heavy lift, but I just was putting feelers out. We inform all the health centers, the 52 health centers in Massachusetts, in vetting different types of AI. And there's so many startups right now, and we're just trying to make sure that we're doing the best we can to like recommend things that will help all of the health centers and vulnerable populations. I'm a manager of a digital equity program, and I just wanted to piggyback on your older adults and just share a story from my quarterly reporting. So we're getting increases in 80 to 89-year-olds using telehealth, and we're getting really, really good feedback on how they were so nervous to use it in the beginning and they were scared, but their caregivers, along with our digital navigators, work together to kind of make it much easier. And then they're reporting like increase in mental health because now they know how to connect with family via video. And so we're just super excited to share that information.
That's amazing. That's wonderful to hear. Wow. Thank you, Casey. Chris, go ahead.
Hi, Chris Field from the University of Pittsburgh. Thanks, really full enough. My only comment is that I would encourage all of us to consider that there is an incredible energy cost that's associated with these tools. And it's not just energy like, oh, I'll put out some solar panels and that'll cover it. These are gigawatt level thresholds of energy. Enough to power entire cities are required to fuel these operations. And it's got to be steady state energy. It can't fluctuate in any capacity or the models will suffer. So as we move forward with this, and I want to embrace this technology, I want all of us to embrace it, particularly in the medical field, particularly for elders and particularly for those who are marginalized from society, so that they can have a full complement of services delivered to them and live a fulfilling life. If these tools can provide that, I want that for them. But we've got to be advocates and thoughtful about how we cherry pick our own politics, because this is going to require maybe energy from sources that we're not comfortable with, like massive natural gas fracking operations. I'm from Pennsylvania, of course, and we're a large exporter of natural gas. I don't like it, but I think I've got to sit and look at that and wrestle with that as my personal politics. If I want this technology, I have to acknowledge how it's going to be fueled and the energy that is required, and who may not be getting energy if we divert it to these technologies. Just something to think about. I don't really have a solution. Thank you very much. It's excellent. It's good to hear from you today.
Thank you so much, Chris. Absolutely. Those are those types of thoughts that we have that I think can be so overwhelming. But absolutely something to consider and think about. I'll read Precious's notes since your mic is not working. As a researcher with the Division of Aging Care Services in Baltimore City, I'm exploring how AI can be used to enhance program service delivery and improve the development of government services. Amazing. Especially interested in the potential to support more responsive and equitable outcomes for older adults and caregivers. I am on the same page. I'd love to have a conversation with you as well and how I can support the efforts. Jinhee. Jinhee, go ahead. You can unmute.
Sorry. I had the great good fortune before my first baby in 1997 and 8 to work with UPMC when they were deciding whether to go, instead of a mainframe, homegrown, in-house built system, to go either Cerner or Epic, or back then Siemens or McKesson, blah, 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 blah. So UPMC has always been on the cutting edge of technology, and I applaud that. As University of Maryland, same thing. University of Maryland beat Pittsburgh to the punch, and Duke, to pick Epic and integrate.
Where's my boxes?
Absolutely. There's lots of it, and we have a new center on AI, and like I said, what I appreciate about the College of Info is that we very much focus on the human aspect, and we're very excited about the technology, but making sure that it's doing good is really important for us. Yeah, lots of exciting things coming, especially out of education, for sure. Tina, repeating for consideration, what about equity in terms of who has access to technology and who is tech savvy enough to know about AI tools? Absolutely. And I don't have a solution, but I have to say, when I was working with AARP a while back, they partnered with Verizon, or I'm sorry, maybe Comcast, in order to get internet access to older adults' homes, especially those individuals in rural areas. And like I said, I think a lot of us don't think about the fact that we have immediate access to Wi-Fi, to a phone, to a computer. So I'm right there with you. And I do what I can on the academic side. And for me, it's very important to partner with local community members and organizations in order to support not only Marylanders online, but really everyone, especially those who don't have access. So that's a huge part of the bias and the equity issues that we're seeing. I absolutely agree. Thank you so much. Thank you so much for these very insightful comments. I apologize, I haven't scrolled up to see anything else, but I really appreciate your time today. I would love to have, I'm gonna drop in my email in the chat. Like I said, my slides are not revolutionary, so I will happily share all of them in a PDF, but it was more about having a conversation, which kind of goes back to the humanness of it all. I really wanted to hear your perspective and hear about where you are in your industry, and sort of how you all are thinking about this. And like I said, my mission really is to make sure that we're developing these tools the right way, deploying them the right way, and making sure they're supporting those who are part of the accessibility community. Please include a phone number. Oh, Tina, I will message you my phone number in the private chat, sure. And I'll drop in my. It has me thinking about Alexa. Yes, please grab an Alexa, grab a Google Home. It's now, my parents, my in-laws, my grandparents, they can't live without them because I made them early adopters. So, and I also want to encourage you to look at Alexa Together, which is that caregiver tool. It's been on the market for quite some time, and I have done research with it, and I think it can be very helpful. By no means am I on Amazon. I don't get anything from them other than I'm really interested in supporting caregivers. So there's my email. Thank you all so much. I really appreciate your time. Thanks again.
Thanks again, Dr. Reitz. And for Dr. Reitz's email, you can also find all the speakers' emails on our website under the speaker page. So just wanted to let you guys know that. And that was really a thought-provoking, and there were so many great tools that you presented. So thank you so much for that, Dr. Galina.
Thank you, everyone. I hope you have a great rest of the conference.
All right, let me go back to share my screen. Okay, so now we're going to take a brief intermission, a 10-minute break. Feel free to turn off your cameras, stretch your legs, and get a beverage. If you're unable to stay for the full conference, please complete the brief survey here. You can do this by scanning the QR code, and we will resume at 11:25 a.m. Thank you, everyone.
Hello, can you hear me now? Can you hear me now? Okay, I can hear. Okay,
Yep.
good.
I can hear you.
What was the issue?
Hi, everyone. It is 11:25, so we will go ahead and resume. Welcome back, everyone. If you can, we do ask if you can please go ahead and turn on your cameras. Just a reminder, don't forget we have the chat if you have questions, and you can use the reaction buttons to participate with the presenters. And if you're just joining and you need instructions to rename, we're going to go ahead and post that in the chat right now. What you'll do is click on the three dots next to your name under the participant list, and then once you click rename, you'll be able to change your screen name. All right. Next, we will hear from Dr. Sandra Saperstein and Dr. Devlin Jackson on the best practices for reaching diverse populations. Dr. Saperstein is an experienced educator teaching courses in public health informatics and social media with a goal of contributing to the development of students who are passionate about public health. She is skilled in public health program planning and evaluation, quantitative and qualitative research, data visualization, and user-centered design. Dr. Jackson is a health communication and culture trained scientist who is deeply passionate about harnessing the power of digital health tools to improve the health and well-being of diverse populations. Her work centers on community collaboration, partnering with communities to co-design, evaluate, and refine health information content that reflect their unique values and lived experiences. Please join me in welcoming Dr. Saperstein and Dr. Jackson.
Hello, everyone. Thank you all for inviting us to be a part of this discussion around digital health and technology and how this can influence and impact health outcomes, as well as improving the health of the communities that we work with. So this morning, Dr. Saperstein and I are going to have a little bit of a discussion as well as provide some insight on best practices for reaching diverse populations as it relates to digital health. And so I'm going to start this talk off first going over identifying and applying cultural appropriate strategies when developing health content, including apps and websites. Thinking about how we can apply a health equity lens to identify and mitigate barriers in your digital health initiatives as we are aiming to move that health equity needle forward. Understanding how co-design can enhance digital health tool adoption. And then I'm going to hand the mic over to my colleague, Dr. Saperstein, where she will dive into identifying and applying accessibility strategies to reach potential audiences and understanding how digital skills gaps can affect digital health tool use. Okay, so with that said, let's go ahead and get started. So in my work, I, as a trained health communication and culture scientist, I believe it's really important that we center the lived experiences of the end user and the community members who are utilizing these digital health content tools. And one approach in which I apply to support centering their voices is applying cultural appropriate strategies. So cultural appropriate strategies, the ones that I apply, were developed by Dr. Kruder a little over 20 years ago, in which he and his colleagues developed 5 strategies that individuals can use in health communication. And so I apply these in my health communication content development work, as well as in my digital health communication research work. So I'm going to go over some of the strategies and talk about them in the context of digital health tools and some ways that one could think about that when applying these strategies. So, why culture matters in digital health? Well, it can contribute to increased engagement and motivation to use those digital health tools, which can lead to health behavior change. And we've realized through research that the one size fits all doesn't always benefit specific groups, and it can contribute to worsening health disparities rather than narrowing those disparities and eliminating them. And so we're going to talk about a little bit later, how do we think about that in the context of applying a health equity lens? But before we move there, let's talk about some of these strategies and how to center the voices of the communities and the end users with these strategies. So one strategy is the peripheral strategy. And this is using design elements like colors that resonate with the community, either culturally or symbolically, as it relates to the health issue or health behavior or their lived experiences. I think about with some of the work that I've done, I've inquired with specifically work that I've done with the African American and Black communities. I have asked, okay, so what colors tend to resonate more when you think about your lived experience? Is it colors as it relates to the Pan-African diaspora? Or are there other colors that speak to your lived experiences? And so that has informed how these digital health tool content is more appealing, more engaging, more inviting for someone to feel and say, oh, this is speaking to me and not just the broader audience. This also, in this peripheral design, when you're thinking about design elements, it also includes images of community or relevant community members. Now, the things that you want to think about and be mindful of when you are selecting images, colors, any symbolism, you want to be mindful that you're not contributing to exacerbating stereotypes. And I'm sure many of us are thinking in this way already, and not doing things that could be possibly offensive or off-putting. One thing that I think about is the work that I've done working with members of the LGBTQ plus community. We have learned working with them to be mindful of rainbow washing. In other words, overuse of the symbolism of the rainbow flag or colors that resonate with the community, because it can give this impression of not being genuine, and really sensitive to thinking about, okay, is this a thoughtful way of using those colors, symbols, and images? Also, when we think about images of community members, right? We know that there is no one community that is monolithic. Every community has its own differences within. And so we want to be mindful, okay, is this image appropriate, or should we be using different images to communicate the differences and honoring the differences within those communities? And also another thing in peripheral is thinking about declarative titles, titles that are very clear that this is for that community, actually saying, for Black young adults, or for the rural adults in X, Y, and Z county. And that is one strategy that one could think about in their digital design, like the way that they put the content in maybe a mobile health app or a patient portal, or how they're marketing their telehealth devices. Another strategy is evidential strategies. And so this is when you're presenting epidemiological or health data specific to that community of focus. Some examples of that is maybe within that portal or within that app or within that wearable. One is speaking specifically, not just on a broader sense of the experiences of diabetes in the US, but if maybe your digital health technology is intended to provide personalized health information, you are providing health information that speaks to that individual's lived experiences, giving them an idea of how other community members within their community are experiencing maybe diabetes, stress management, and also thinking about when you're communicating that data and being mindful of not exacerbating stereotypes or giving this impression of blaming or shaming a community. You want to think about how you're framing it. So you'll notice here in the two data points that I provide, one is showing the more traditional convention of this is the experience of those that have diabetes compared to another community. But then I'm also pointing out that we can also use opportunities to talk about in a non-deficit way, right? And talking about how a specific community is engaging in healthy stress management activities, such as meditation, rather than not engaging in those management activities, because that can also impact how someone is cognitively processing and perceiving how a digital health content or platform is speaking to their lived experiences or trying to connect with them. So that is one way of applying cultural appropriate strategies. And then the last thing that I will just offer when thinking about evidential strategies in how you frame this data is giving context to what this data means to ensure that we're not perpetuating certain stereotypes or shaming, right? So explaining that a lot of this data is rooted in systemic factors, institutional factors, external factors that have created inequities and limited access, which have influenced these health outcomes that these communities are experiencing. So it's really important to provide that context so then communities don't feel that when they see this information in these digital health content that's supposed to motivate them or bring awareness to them or inspire them, that they don't view it as this is my fault, but rather recognizing there are systems that also play a role in why I have these lived experiences that I have. Another strategy is linguistic. And so this is adapting the content to the primary and preferred language of the community. So this can be viewed in multiple ways. One, we can think about community cultural language as in nationality. So if someone speaks Spanish, Creole, French, Urdu, Chinese, and so forth. And we can also think about community cultural language as it relates to popular culture. We can think about cultural language in specifically to how certain generations speak, how a certain culture, like terms that have been created by cultures, like within the Black community or within the LGBTQ plus community or within certain intersecting identity communities. And so that can be a way to make that content more relevant. But once again, and you'll probably continue to hear me say this, is thinking about, okay, is that appropriate to use? Could it be off-putting? Could it look as though this is the out group trying to be within a group rather than a language that is speaking to the community? And so that is something that you want to think about. And I'm going to talk about ways to ensure, okay, is this the appropriate strategy to use when considering linguistic strategies as far as those community cultural languages that one would include in their digital health content? And then another another strategy is sociocultural strategy. So this is when one is embedding the community's cultural beliefs, values, traditions, and social norms in the content. And examples may be based on traditions, such as religion, family, rituals, etc. One example of this that I think about in digital health content in present day, right, is we have these really cool physical health or physical activity devices that are promoting and encouraging us to get our heart rates up, go out there and exercise, and so forth. Well, when I think culturally, and I'm gonna center myself for a moment. When I think culturally as a Black woman who wears her hair currently straightened, but when it's not straightened, it is naturally curlier texture. Well, when I'm working out and exercising, I have to think about that perspiration, that sweat, and how my hair might start to curl up when I've spent all this time, hours, and even money straightening my hair, right? And so I think about in the context, and a scholar, and I'm missing her name at the moment, but over 15 years ago wrote this excellent article that talked about the socio-cultural values and beliefs and practices of Black women and their hair, and how that is something that someone should be taking in consideration of when thinking about physical activity. So when I think about digital health content, if we are encouraging communities to engage in physical activity, to exercise, right? But maybe a concern is something like hair. What would that messaging look like in there? So before one goes to engage on that run or engage in that high intensity interval workout training, are we also acknowledging that they might have some hesitation? And should we think about including some content about, wrapping up the hair, or don't forget, because I know you already thinking about it. So maybe you may want to wrap up your hair before you jump on that treadmill so that you can maintain that dew, right? Or other things that might be of value to them. So that's one example when you think about sociocultural, and hopefully that example that I provided is having you to think about like other communities and their experiences that they've shared with you. And you're like, oh, okay. This is one way that we might want to think about our wearable content or our mobile health content or how we're using telehealth. And then the last one that I want to offer and share with the group from Kruder and his colleagues is the constituent involving. So this is engaging members of the target community in the planning, creation, and dissemination of content. And so this can look like co-designing or co-creation, which I'm going to talk about in a moment, where they are part of giving input and letting you know, like, don't use that language. Or, you know what? I love those types of images. And I'm also hearing from friends and family, they would want to see more of that. Or I don't know about saying the data that way, because this is making me feel like this when you frame it in that context. Or actually, this is a really cool device, but right now it feels like it could be for anyone. So how do you make this really speak to my lived experiences as X, Y, and Z, right? And so that is one aspect of constituent involvement. But then the other aspect of constituent involvement is making sure the voices of these community members are present in the content if they feel that that is appropriate. So when I say their voices in the content, like their testimonies, right? So that other community members can hear from someone like them. They can hear their successes, they can hear their challenges, they can hear how they're overcoming certain things or how they're engaging in certain health behaviors or navigating that digital health tool. And so those are some ways that constituent involvement can be very beneficial. So those are the cultural appropriate strategies that one could apply in digital health communication development. And so, as I had mentioned before, these strategies can be great. However, it's really important to recognize that you don't want to just apply them without also applying a health equity lens to ensure that we're identifying and mitigating barriers in our digital health initiatives. And when we are engaging in applying that health equity lens, it's encouraged to ask ourselves some questions when we are deciding to what digital health tools we're going to design, which digital health tools we're going to implement, and what that content in those tools would look like. So the Ontario Public Health Association developed this position statement, and I have the link down here at the bottom on the slides, that suggested and encouraged that when you are creating any type of public health initiative, that you apply this health equity lens and answer these questions. Now, we have probably already seen some other models of applying health equity lens, but I really appreciate these questions, and I adapted them to include digital health tools specifically. You could apply it to any other public health initiative. But I think these are really great questions to think about, because sometimes we create these really cool devices, but they might be creating some exclusion points. And so when I think about the question, could the planned digital health tool, like an app, telehealth, patient portal, wearable, and so forth, have a negative impact on the community? And if so, how can the negative inequitable impacts be mitigated and addressed? I think about things like, okay, in something like that, I might ask, will this tool exclude individuals who lack access to smartphones or broadband internet or digital literacy skills, which my colleague, Dr. Saperstein, is going to talk more about? And so how might we mitigate that? Would it be by providing alternative access methods like an SMS-based version, or a phone-based support like a kiosk in clinics, or digital navigators? Or what about bias in algorithms? Some of our colleagues earlier today and the panelists have been talking about algorithms and have mentioned some of the challenges and successes and opportunities there. And so are we asking ourselves questions like, to support this first bullet, does the tool's algorithm or content reflect biases like racial, gender, linguistic, that could lead to misdiagnosis or unequal treatment? And then moving on to the second question, how do we consider the needs, preferences, and lived experiences of the community in the digital health tool? Well, this is where I love one of my favorite approaches that I apply in the work, which is co-design. We can really get at understanding what they want as it relates to their lived experiences by involving co-design, by thinking about, doing user testing, which Dr. Saperstein is going to talk about in a moment. And then language and accessibility. Is the tool available in the preferred languages and literacy levels of the target population? Are we thinking about different abilities and the inclusion of that? Does the tool accommodate people with different abilities regarding visual, hearing, or cognitive? And then the last one, how will the planned digital health tool address the social determinants of health, right? Because we know our social determinants of health are shaped by where we live, work, and play. And so questions that we might ask there are things like, does the tool help users connect to food, housing, transportation, or financial assistance resources? Have we embedded directories or referral pathways for social support services, recognizing that these determinants of health might be impacting how they're engaging in those digital health tools, or contributing to being successful in that particular health behavior? Or things like, does the digital health tool capture information about the user's social determinants of health, like housing and food stability and food security, excuse me? And so in the last part that I want to talk about when thinking about that's connecting the health equity lens to one of my favorite approaches that I center my work in is the co-design approach. I had mentioned before in this second bullet that we can really start to move that needle towards achieving health equity by involving the community members in this process. And one of the processes is called co-design. And in that co-design process, we can get the answers to these questions that you see here, right? Instead of us trying to figure out like, how should we mitigate this? How should we go about planning? We can get those answers through involving them through the process. So let's talk about what that looks like and understanding how co-design can enhance digital health adoption. So what is co-design? So some of you may already be familiar, and so this will be a refresher, and then those who are not, just want to introduce you to the concept, which is a collaborative design approach where the end users of that product, and this co-design can be applied to many different things, but when I'm talking today, I'm discussing in the context product of digital health, is actively involved in the designing. It centers the voices of the community, contributing to addressing health disparities, and can produce a more inclusive, accessible, and effective tool. So what I'm going to share with you to give you an idea of what that would look like is a research project that I actually served as one of the co-leads on, where we were funded by the National Institutes of Health, National Library of Medicine. Dr. Cynthia Bauer served as the principal investigator of this project. I was the project director as well as the co-lead of the co-designing sessions with the African American and Black Hispanic adult community members. And so we were tasked within that grant. Our aim was to initially develop a personalized health information app that aligned with the health goals and personal family health histories for English speaking and bilingual Black and Hispanic adults. And the name of this app was called Healthy Me or Mi Salud. Not was, is, because it exists. And community partners provided input as well as the Black and Hispanic adult community members throughout the co-design process to develop this app. So in that co-designing process, we applied, so there's several common co-design approaches that one could apply, and we applied the participatory design session approach, where in this, we did 3 design sessions with the community members. The first one was collage and card sorting. And so here's an image over here to the right that depicts what that looked like. So we asked them to, in a creative, artistic, engaging process, to express their ideas and thoughts about what does prevention look like for you? What would that look like in content, in information, in a tool like an app? That would really resonate and connect with you when you think about the definition of preventing, the definitions of managing and achieving certain health behaviors. Then after we received that information from them, that helped to then build and refine our app prototype that we were designing with the community members. After refining that app prototype, we then moved to session 2, where we did some usability testing and we performed some tasks with them. So we asked them to engage with different features of the app, asking about content of the app and thinking out loud that process as they were actually using the prototype, in which was informed by their feedback from session 1. Then we moved on to session 3, where we did a deeper dive in applying cultural strategies. So those cultural strategies that we discussed earlier, we asked them, okay, so how do you feel about more evidential content that speaks specifically to you, to your community, or would you prefer it at a broader space? We then asked about imagery, colors. We also asked about sociocultural factors, because in earlier sessions, they had talked about how for some folks, religion was important to them, how mental health was important, but there were some beliefs and attitudes around mental health in that space and how we needed to revise that. Those are some examples of that cultural appropriate strategies. And so what we learned from those design sessions was that the participants shared with us, it was an opportunity for their views to be heard. They were like, we've been heard, and we really enjoy too working together in a design process for something that is for us. And essentially it feels like it's also by us. And then it reduced apprehension about mHealth. So some of our community members had a lot of familiarity with digital tools, and then others did not. And so individuals saying being a part of this design process reduced some of the apprehension that they came in with around digital tools as well as digital health tools. And it was an opportunity for them to increase their knowledge of how to manage their own health through mHealth. So if you'd like to learn a little bit more about the details of that study, here's the publication that we published in 2022 of that particular process with our colleagues, Dr. Neil Siegel and Cynthia Bauer. And I also encourage that if you want to learn more or hear more, or even collaborate with me on some of these approaches that we do in my work, working with communities around digital health and co-design, I encourage you to check out my research lab called Dig Inclusive, and which will be launching the website coming soon. And so at this point, I'm going to hand the mic over to Dr. Sapersoon, who's going to talk more about that accessibility and different ways to engage. Thank you all.
Thanks, Dr. Jackson. I'm going to share my screen. Okay, so can y'all can see that? I just messed up my whole desktop. So I'm going to talk to you about identifying and applying accessibility strategies to better reach our audiences. And accessibility is defined as the degree to which our products, our services, our environments are usable by as many people as possible. And when we're talking about accessibility, we do have a focus on people with disabilities. So why should we design for accessibility? The bottom line is it's really just the right thing to do. We know from CDC data that 1 in 4 American adults has some kind of a disability. So I am always thinking about that. I'm always going to have somebody with some kind of disability in my audience. When we design for accessibility, all of our audiences have a better experience and have greater satisfaction with the product that you're developing. And in the case of a website, an accessible website will have better search engine optimization, meaning it will show up higher in search results, so more people will find your work. There can be a variety of impairments or differences in how our bodies function that underlie disability. These can be sensory in terms of how people can see or hear. They can be motor in terms of physical disabilities. It could be cognitive, how we take in and process information. And it can also, we can also have impairments with our mental and emotional state. So having impairments in any or in combination of these systems can affect our ability to use e-health tools. So I'm going to walk through tips for accessible design. These are going to be 7 high-level tips. You can continue to do deeper dive and learning as you continue in your journey to creating accessible design. The first one, and I think the most important one, is using plain language. That's language that your audience understands the first time they hear it, see it, or read it. It lets people find what they need, understand what they find, and then use that information to make informed decisions. And this is really important for everybody. It is not just for people who maybe have less education or lower literacy. I have worked with many people. In a past life, I was an occupational therapist who had very high levels of education. And when you're faced with a disability or a health condition, you don't process information in the same way. So plain language is important for everybody. I want to share a few tips for plain language. I'm showing this first example related to a social media post, but this really applies to any tool. You want to have a clear main message. What is it that you really want to tell your audience? Telling your audience that this is going to be about dementia isn't enough. You want to give them, tell me that after I've engaged here, you're going to know how to reduce your risk. You then want to think about all your content and using headings or lists to organize your information so that your users can find it. And you want to make sure that you include a call to action. What is it that you want people to do after they have engaged with your tool or your material? If you're thinking about websites, there's some more things that you can be thinking about. Again, this idea of having meaningful headings and questions are often a really good way to frame this. And I will share that I came across this website because my son recently had a Colles fracture. So I was trying to find out more about a Colles fracture. And I just thought this was a beautiful example of plain language from Cleveland Clinic. You also want to make sure your content is in simple and understandable sentences and that you define jargon and unfamiliar terms. And so right here in the second sentence, they use the term distal to describe this fracture, and they immediately give a definition away from the center of the body. You also want to be writing an active voice and talking to your audience. I think a lot of times we talk about our audiences and not to them. So this sentence, go to your nearest emergency room if you suspect you have any type of wrist fracture. And then lastly, if you are on a web page and you're including links to additional material, you want to use meaningful links. So if you have somebody who's accessing your page who's blind and using a screen reader, they can call up all the links that are on the page. And so if you just have your links listed as click here for more, click here for more, click here for more, your users using screen readers will not know what they are clicking here for more. I also want to give a shout out, if you want to learn more about plain language, visit the Consumer Health Information Hub. And I see that Dr. Mayberry is in the audience, so shout out to Dr. Mayberry and Dr. Bauer. Anything you want to learn about plain language, you can find here. I mentioned that in addition to thinking through your main message, you want to make sure your content is organized so people can find it. But I want to emphasize that you should use proper formatting for your headings and lists. So I've watched a lot of people, oh, I'm going to make a heading, so let me bump up the font to 20 and I'm going to use bold. Well, a screen reader would not be able to understand that that's a heading. So you want to use the built-in styles that are available in your tools. Another accessibility tip is using alt text. So if you have a user who's blind and using a screen reader, alt text will describe any of the images that you are sharing. This can also be really helpful if you have slow internet and images take longer to download. The alt text will show up and you can understand what's going on. In a lot of our tools, it's really easy to add alt text. So in these, we use Google Slides for this presentation. If I right-click on my image, I will get a menu of options. And this is just a piece of it, but I can just simply add my description in so it's available for people. The next tip is making sure you have high color contrast between your font and the background. And this will benefit users who have low vision. And I love this tool from an organization called WebAIM, where you can actually check it to see if you have enough contrast. So I use this tool to look at this red color by putting in the 6-digit hex code that goes with this red against the white background. And I can see that in most situations, the contrast was adequate, but in one I fail. So this smaller text here is really not adequate for helping people with low vision access this slide. If you're designing materials and you have a visual that's interesting and but might create a problem when you're putting your font over it, just put a little shape behind it to build that color contrast, and it takes nothing away from your image. The next tip is adding captions to your videos. This benefits people who are deaf or hard of hearing. But I do want to say, if you have an audience that includes people who are deaf, whose first language is American Sign Language, then having sign language interpretation is really a better choice. Captions can help. They can also benefit people who are English language learners, people with learning disabilities, people who might be in situations where you need to watch, but you don't want the sound on. I want to distinguish for you closed versus open captions. Closed captions are ideal. It allows users to turn them on and off, and that's really preferred. While captions can help a lot of people, for some people, they might be distracting. It might be too much input, so they might want to shut them off. I will say that our social media platforms in general don't make it easy to put up videos with closed captions. So another option are open captions, which are burned right into the video. And I want to share just a couple of captioning hints. The first is, if you're using a tool that auto-generates your captions, you must edit them. A lot of auto-generation tools don't have capitalization or punctuation, and they get words wrong. So back during the pandemic, when I was making a lot of videos, and in one video I was talking about HIPAA, which is regulations around protecting personal health information. And the automatic captions changed all my HIPAAs to hip hop, which would have made me maybe a cooler instructor, but it wasn't really what I was talking about. Adobe Express is my new favorite tool for open captions. Super easy to use. We put the link in the chat, but basically you upload your video, it'll chug for a little bit, and then it will give you this easy interface to edit the captions. This is the first tool I've used that actually has punctuation and capitalization, but you still have to edit. And I will caution you, they give you a lot of different styles for what those captions can look like. Stick with the basic, black background, white letters to have adequate contrast. Another tip is camel casing your hashtags. And it's when you are using hashtags where you're running a lot of words together, you want to capitalize each word, like in the title here for a camel case. Again, this is something that will benefit people who are using screen readers, because screen readers will try to read that all as one word. Will also help people with learning disabilities to parse those words out. And so an example here is if I used this hashtag, a screen reader could potentially read this as hashtag Super Bowl or hashtag superb owl. So camel casing can help avoid those kinds of issues. The last thing I want to say, and this ties back to what Dr. Jackson mentioned before about providing materials in languages that your audience speaks. We need to think about translating our written materials as really a deliberate step in accessibility. So you have to know what languages your audience speaks. You have to allocate resources in your planning and budgeting step to make sure you have a budget for the translation process. It will be really helpful if you've made sure your plain language materials are final before you send those for translation. And then lastly, you want to leave time for design because different materials take up space differently. And so you might have had a beautiful template for your social media or for your app. But if you might need time to redesign to fit longer words in different languages. And I know some people are going to talk about, and some of the sessions earlier today mentioned Google Translate. We are starting to see studies that are looking at the accuracy. So one study found an 83% accuracy translating emergency room instructions, but the full range went from 55% to 94%. And then a more recent study looked at differences in Google Translate with 3 languages, Spanish, Portuguese, and Haitian Creole. And they found that the errors in Haitian Creole were more serious with potential for clinical harm. So at this point, I would say that you need to not rely on Google Translate to translate important health information. But I know these tools are getting better and better, so I would suggest you keep your eyes on the research. So accessibility can be a lot. I encourage you to get started and to do this and think about this when you are creating materials or tools. I think one thing that helps is to find your why as your motivation for taking these steps. You know, I've heard people say, oh, it's a lot, it's so hard to do this. It doesn't have to be. When you center yourself on the fact that accessibility is really an equity issue and you want all people to benefit from your materials. You know, your why might be around that you want to be an excellent service provider or communicator, or maybe you've got personal experiences with disability, or maybe you are simply meeting legal requirements, but that why can help drive you. And then take some small steps. Some of these tips that I've shared are pretty easy to do, pretty straightforward. And when you start thinking about them in the development process, it's easier to get on board with it. So, you know, we've been thinking about the fact that our materials need to speak to our audiences culturally, they need to be accessible to all people. But I do want to highlight the fact that we do have gaps in digital skills that are going to affect how and to what degree people can successfully use our tools. And I think a lot of us who are very skilled in using digital tools don't really understand the degree of this gap in foundational skills. We have people who struggle just with the technology itself. How do I turn on a computer? How do I use a mouse? What does it mean if I'm swiping or tapping or double tapping on my phone? At the next level up, it's the ability to do specific tasks, send an email, search for information, create a presentation, use dual authentication, download and use an app on your phone. So task-specific skills. And then the ability to generalize. Does what I learned in this one tool, can I use it in another tool? So I encourage you, if you are somebody in our audience who is thinking about developing tools, to not skip this co-design process that Dr. Jackson talked about earlier. Think about, are you using cultural tailoring strategies? Are you addressing accessibility? And most importantly, when we're thinking about digital skills gaps, have you done usability testing? And Dr. Jackson talked about this a little bit, but people shouldn't be overwhelmed by usability testing. It really doesn't have to be hard. You create a list of tasks that people might use your product for and watch people as they use them. And in the usability world, oftentimes 5 people is enough to highlight your biggest issues. So you want to watch people as they use their tools. You want to see, can they find what they're looking for? What kind of mistakes do they make? Does it take them 6 clicks to get to the right information? And then ask them, oh, how could we make this product easier for somebody like you to use? And then you make those adjustments. So we need to design our tools in a way so that people with the most limited digital skills can take advantage of them. If you're a service provider, I want you to think about all the ways you are communicating with your audience. Is it a website? Is it a portal? Is it telemedicine? Is it social media? Is it an app? And think about, how can you support your audience in using these tools? Are you selecting materials that are culturally relevant and accessible? What digital skills are required to use those tools? Could you have a staff member teach somebody how to use a patient portal? Could you provide video instruction? And maybe could you provide resources to where people can go to build their digital skills? That's a shout out to Marylanders Online and digital skills training. And if you are a digital skills trainer or a digital navigator, keep doing what you're doing. It's so important. You are out there listening, observing, identifying people's challenges, and helping them address their challenges through fundamental skills training. And the impact on people's confidence and skills is what's going to drive them to continue trying and being able to benefit from digital tools and resources. So I want to just kind of close us out by saying we really can't underestimate the importance of this work. When we design for accessibility, cultural inclusion, and digital skills, we lift everybody up and give them a chance to benefit and achieve health equity. I wanted to share a couple of quotes. The first one comes from Dr. Jackson's research in co-design and how important that process was for participants. And Dr. Jackson, if you want to add anything, jump in. But this participant said, I like that you take our views and perspectives into account as elders and facilitate access to cell phone research. And the other quote on here was from a digital skills class participant. So in my other hat, I will share that I am involved as the evaluator for Marylanders Online. And I talk to participants in the digital skills classes. And this one woman described to me how she'd go to her doctor's office and there was a computer or an iPad that you could check in with, and she never knew how to do it. And she'd have to wait on the long line and she felt left out. She took the digital skills class and she went in and she was like, I know how to do this. She registered herself. And then a woman behind her said, hey, could you show me how to do this? And she said, I can. I really can. And I showed her how to do it. And she said, I'm so happy. The class made me feel confident. It made me feel like I can do things. And so, you know, we are believers in the importance of this work. And we'll stop here and open the floor for any questions.
So would you like me to read the questions to you that are in the chat? That'd be an easier way for you to answer them.
Yeah, that would be great,
Okay,
because I
great.
actually haven't had the chat open.
Okay, so the first question is, thank you for sharing this valuable information. As a part-time digital navigator, I often observe these digital skills gaps in the communities I serve. So your presentation was especially relevant and deeply appreciated. It has also served as a great refresher training for me. Would you be willing to share your slides as well? I found the content helpful.
Yeah, absolutely. Dr. Jackson, I'm speaking for you too. Are you comfortable hearing our slides?
Great, and there's a bunch of comments below that just telling you that the presentation is very insightful and informative. They love the story and that it's great. So I don't see any other actual questions beyond those comments, but lots of great feedback here.
Great. Well, thank you all so much. And you'll have our contact information. We'd love to hear from you.
Well, thank you both so much for your time.
Thank you so much. Just wanted to open up the floor once more just to see if anyone has any final questions for Dr. Jackson or Dr. Saperstein. No? Okay. Sounds good. Thank you so much for your help, Dr. Saperstein and Dr. Jackson, for presenting this and for coming. We really appreciate it. It was very informative and valuable. I will go ahead and share my screen before we head off to lunch. Can everyone view my screen? Just want to check.
Yes.
All right, sounds good. So we're now going to take a break for lunch. You'll have an hour to grab something to eat and take a break. If you're unable to stay for the remainder of the conference, please remember to scan the QR code here and complete our brief survey. And thank you all for joining us so far. We will see you guys at 1:25 p.m. for the next presentation. So now we're excited to continue the conversation with a panel of incredible individuals who will be discussing some of the most pressing issues at the intersection of health and technology. Leading this important discussion is Isaias Tesfaldet. Isaias is a program leader for Marylanders Online, where he focuses on bridging the digital divide and ensuring that communities across the state have access to the tools, skills, and support they need to thrive in today's digital world. And for our panelists, please join me in welcoming Sarah Rampor, Charlotte Avery, Stefano Solorio, and Amy Schoen. Thank you, Isaias. The floor is yours.
Thank you. Really great conference today. So our panel is an interactive panel, and we'll have question and answer. The title is Exploring Key Issues in Health and Technology. As Neri said, my name is Isaias Tesfaldet. I'm the director of the Marylanders Online Digital Literacy Project. Just for general background and context, we are housed within the Family and Consumer Sciences program at the University of Maryland Extension. The University of Maryland Extension is part of the College of Agriculture and Natural Resources. And Extension has offices in all Maryland jurisdictions, the 23 counties plus Baltimore City. Marylanders Online is funded from the American Rescue Plan Act. We have educators, digital navigators, digital skills training modules, and curriculum repository. Really excited to have this discussion. So briefly, we're joined by Amy Schoen. She'll introduce herself and describe how the work she does is related to the theme of the panel. The same with Stefano Solorio, Sarah Irampur, and I think we have all of our panelists, Charlotte Every. So I will start with Stefano with the first question. If any one of you has slide deck you want to share, please let Naris know. It might be 1 or 2 slides. This will be interactive panel, but we'll start with Stefano. So the question is, could you briefly introduce yourself, who you are, what you do, and then share how your work connects with the theme of the conference today and this panel. So Stefano.
I was about to say we're missing one panelist.
Oh,
I'm here actually. Charlotte is here.
Yeah. I was like, no. It was Julie, but now it's Charlotte. Yeah. Well, good afternoon, everybody. Thank you so much, Isaias, and as well as the Marylanders Extension team for putting this together. I'll start with introducing myself. My name is Stefano Solorio. I founded a company back in 2020 to help the aging population learn more about technology. And over the years, we've done some work with senior living communities, primary care clinics, and most notably, we work with a Medicare Advantage plan, which you may all probably know, Humana. And we served about 23,000 of their patients, getting their patients to be more digital health literate when it comes to accessing telehealth, patient portals, and a variety of technology education they can receive. And it was such a great experience working with that group. And I'm here today to share, obviously, some of the work that we're doing now, especially when it comes to artificial intelligence and how we're expanding our work in that field. But mostly just to share about some of the awesome stuff and hear about the awesome stuff that my co-panelists are doing as well. So thank you very much, Isaias.
Thank you. Next, we'll go to Sarah. The same question.
Very happy to be here. Thank you much, everyone. Since it is afternoon and energy might dip a little bit, I created a couple of slides, colorful slides. Could I share my screen?
Yeah, I think I should be able to do that, yeah.
Okay, let me see. Okay. Let's see how it goes, because when we share a screen, it's gonna take, okay, share screen, share, and does everyone see my screen? Yes?
Yes.
Perfect. So basically, Maryland, as we know all, is one of the most diverse states in the nation, and yet the gap in care are staggering. I'm not going to go deep in the issues. I think we all know it. The foundation of healthy community, thriving community is to address the foundation of social services and then mental health on top of that, and how we are relevant to this, what we're doing. I'm managing a technology company for last 12 years, actually last 16 years, but for last 12 years, we're focusing on a health IT and digitalization technology digest, and then Person Clinic, which I was introduced under in this event, is the sister company of that, which focus on mental health. So what we have done during last decade, we work with researchers and local government to digitalize and their initiatives and bring to life what they envisioning for addressing this issue. So the very, one of the, the prior question was who you were impressed. Although I couldn't say Montgomery County as a research county, but their Community Connect initiative, which basically digitalize, digitalize the whole social services. We led that development for them, and that it is in 7 languages. provide families with 24/7 digital access to vital services like childcare, housing, assistance, public resources, streamlining access to reducing paperwork, and make it easier for everyone to access that. That is the product that we created for Montgomery County, and that initiative is going on. But Person is in-house product. It's supported with a patent. It's a patented digital platform that sits on the intersection of personalized treatment and helping researchers to create personalized drug and treatment. So it brings these two universes together. It provides peer-to-peer support, telehealth, biometric monitoring, educational tool, offers personalized and measurable holistic care. And as I mentioned, oh, sorry. I'm clicking between. It has an embedded virtual clinical trial that enables researchers to create more personalized and holistic, equitable treatment. The AI is not magic. It is a prediction. Again, I wanted to repeat this. AI is not magic. It's a prediction. And the future belongs to those who master systems and judgment. And that has to be derived by citizens. That has to be derived. Therefore, the data has to be derived by citizens. Data has to be owned by people. And that is what we are passionate. We are passionate about developing systems and bringing platform to the market that really echoing the voice of the patients. So as you see, our impact is already viable. We're working with counties to digitalize their support systems. We're conducting virtual clinical trials through Person, and we're providing a dashboard that enables the decision maker with a better decision. So very happy to be here. My contact information, looking to partner with you all. If any question. Thank you.
Thank you. So we'll go through each of the panelists and then we'll accept questions. The questions will come through the chat and then we'll allow people to pick up the mic and speak. Next is Charlotte. Did I pronounce your name correctly?
Yes.
Okay.
So sorry. We do have one question for Sarah here.
Sure.
Only because I'm an elderly woman and I'll forget. Sarah, do you have a picture of the dashboard that maybe while Charlotte's presenting, you could just give us a peek at what you mean when you say dashboard?
I don't have it handy here, but I definitely can provide you. And if you're interested, I can provide you a demo.
Thank you so much.
And I have my contact information there, and I think you can get it. So just send me an email. More than happy. Thank you.
Thank you. Go ahead, Charlotte.
Hello, everyone. Thank you for having me here. My name is Charlotte Avery. I'm the Program Impact Manager for 2 AI institutes here at the University of Maryland in College Park. The first institute is the Artificial Intelligence Interdisciplinary Institute at Maryland, which we also call AIM. This particular institute supports interdisciplinary research and education, and its main tool, the main piece of it is to promote responsible, ethical, and trustworthy AI usage, as well as prepare the future workforce with being able to navigate this new AI-infused, very public world. And so we, our institute centers itself on 4 pillars, where we look at accessibility, sustainability, social justice, and learning. And as Dr. McGrew said earlier, we had AI plus learning symposium yesterday. And so we invited as many people as we could, as we were also launching a new educational institute, statistical institute. And so the second institute that I also represent is Trustworthy AI in Law and Society, which is also known as TRAILS. And this particular institute, it is a four-part partnership where we collaborate with George Washington University, Cornell University, and Morgan State University, and producing technology, governance, and design frameworks and technology where we can definitely lean ourselves as to focusing on the oversight of our AI systems themselves. And through this collaboration, this also includes looking at AI literacy as it relates to those particular areas. And so this is my background. I also am a former educator. I worked in Prince George's County, and through all of these experiences, it has informed my passions for just building and supporting our adult population when it comes to this AI and building out their literacy and specifically targeting our underserved communities, whether they are rural or urban areas. Thank you.
Isaiah, you're on mute.
Did you do that to me, Stefano? All right, okay. But thank you for sharing that. So one of our team members has been selected to be a research affiliate with AIM, Pawan. So my background is in law. I'm a lawyer by training. So happy to collaborate in the future. One of the papers we're trying to go work with Pawan is on AI models and liability, that kind of discussion. So really good information. The next person is Amy. Amy, go ahead.
Sure. Hi, thanks so much. And I really appreciate the invitation and meeting the other panelists and the rest of the attendees today. I have recently moved back to Maryland after 25 years living in Ohio and Michigan. But when I started out here, I worked on USAID studies doing demographic and health surveys abroad. And then I worked under Tony Fauci on HIV vaccines and prevention. And my whole career has really been at the interface of working with vulnerable populations and social determinants of health. So pretty much my entire life is canceled officially, but I'm finding my way to muster it through. I was working for the past decade at School of Medicine in Cleveland, Ohio at Case Western Reserve, where my day job was standing up and running a open data portal that was showing geographic disparities in health, which across the city of Cleveland is a 24-year difference of life expectancy, and then all the other social determinants of health. And it was during that time that the first maps came out, census tract level maps came out about broadband, and it showed exactly the same maps of segregation, poverty, poor health outcomes, and life expectancy. And it was my colleagues in Cleveland who actually, I think were the first ones to really discover digital redlining because of what was going on in Cleveland. And so I was very fortunate because of that to kind of be at the ground floor for the launch of NDIA, which is the National Digital Inclusion Alliance. At the same time, around 2014, patient portals had just come out, and I looked at them as sort of the greatest public health invention of my lifetime, but that public health wasn't really aware of it, and health system didn't know what to do with it. So I started training community health workers to train people to use their portals. And DIA invited me to become a senior fellow. I started a month before the pandemic. And so I spent my fellowship sort of adapting the model for digital health navigators that I was developing as they were launching the digital navigator model that's really taken off across the country. So a few months into the pandemic, I started getting phone calls. The first one, the Cleveland Clinic. We know you've been trying to get our attention around how to connect electronically with our patients. You have our attention. And then I got a call to help establish the Telehealth Equity Coalition. And so with that, I thought I'll never have a better opportunity to really make an impact on what I'm so passionate about. So I quit my job 4.5 years ago and have been doing full-time consulting ever since. So I work with health systems and help them on screening for digital inclusion and workflows for referring patients to community-based digital inclusion organizations. Basically, I help digital inclusion organizations know how to work with healthcare and make healthcare aware that digital inclusion exists and all it can do. So I'm of the belief that health systems have a bigger potential than pretty much any other organization to really identify all the digital gaps and address them. It was very frustrating to me when the ACP was available that people in healthcare didn't wake up every morning and say, oh my gosh, how many people can we get on this benefit program? Because there's never been anything like this. And so once ACP was gone, I think they sort of, figured it out with some regret. And anyway, so I work with them. I work with some technology companies, including one that I'm just starting to talk with about some AI applications. So I'll probably say a little bit more about that later. But anyway, thank you again for having me.
Thank you. So I will put the question that's in the chat. I'll read it as presented.
You want me to jump in on that? So
yeah, for us idiots.
Digital redlining takes its name from economic redlining, which was the legal discriminatory practices by the banking and housing industry after the Depression, where they sent assessors out to every neighborhood and they literally took a map and they colored neighborhoods in red to say banks should not lend here because there were undesirable immigrants, Blacks, Jews, and so those practices became illegal in the 1960s, but the damage from that has not stopped. And so digital redlining was a phenomenon that internet service providers also picked and chose legally where they would serve. And it turns out there's a huge amount of geographic overlap in where internet service providers did not go. And as a result of that, people who are living in low-income neighborhoods, have lower levels of education, are Black in particular, more than Hispanic, did not have access to high-speed internet and were 20 years behind other people in really having the opportunity to develop those skills and develop their communities. So I wrote a health policy brief about that in Health Affairs a year ago, and I can put a link to it in the chat.
Thank you, Amy. So that takes us to the policy, regulation, and innovation question. So what do each one of you see the biggest regulatory challenges in integrating AI? And broadly emerging technologies, right? So AI is one of those. In healthcare specifically, and how can policymakers balance innovation, patient safety, access, data? This is a really broad question, but from your vantage point, from the work that you're actually doing day to day, what regulatory issues do you face and how do you deal with them? And I can ask Sarah maybe, because you've helped some counties to, yeah.
Sure. I'm more than happy. It's one of the things that we face a lot. I think when we looking at the challenges, I can categorize them to 3 areas, and they are very well interconnected. Why transparency and explainable AI, which I will explain what it is, then data privacy and security, and also equity and bias mitigation, which they are all related. So the first challenge in 2023, there was a survey among healthcare leaders, and 60% they were reluctant to accept AI-generated decision. And the reason was because they look at the AI engine as a black box. There's no transparency that how that AI engine has created that decision. So AI has a huge potential, but until we really be transparent about how those algorithm works and what are those decision based, we will see that resistance from healthcare leaders. At the same time, these AIs using the large data model, diverse data sets. Now the question is how these companies access these large data sets, and we will see a gray area when it comes to medical and commercial data handling. So the next question is the HIPAA really efficient and best way to go about it? So FDA is, I think FDA regulatory pathway is not equipped and cannot handle this adaptive continuously learning system. The HIPAA regulation hasn't been able to really protect patients' data. In 2023, we had, about 133 million patient record was hacked. So that's the area that we need to address. But then on the top of that, I think the most important part is, if you look at the clinical trial process, traditionally, the participant in clinical trial, traditionally, they were about more than 90% white male. Today is 77% white male. What does it mean? The data we have is from one subset of population, not whole population. Black and African American, their data within the clinical trial space is only 14%. For women and older population is underrepresented. So we see that when it comes to the even AI and AI diagnostic and drug development using AI model, again, AI system can replicate and amplify the health disparities if it's not trained on large data set representative all the different people and populations. So and that has resulted, actually we saw some of the result, some of the AI model misdiagnosed Black patient up to 20% more frequently than white patients. So this is a paper that was published in Nature Medicine in 2020, not long ago. So again, if you wanted to categorize them, from technology standpoint and from patient voice, I see it 3 area: transparency, data privacy and security, and equity are the 3 area we have to pay attention.
Thank you, Sarah. So, Amy, if I can ask you just to follow up on that question, and you can respond to what Sarah was saying and the general question: how do we deal with this regulation, that kind of thing? And
yeah, to be honest, I have a lot more questions than I have answers. And a lot of it is frankly really idiosyncratic from my own experiences, where I have created private AIs so that I pay for ChatGPT and the data don't, go out to the internet. But I have created a AI neurologist, an AI psychologist / psychiatrist, an IT support for myself, and a research assistant to help me with this policy brief that I'm writing. And as a sort of test, I created one for a friend of mine who has a rare disease that is one of those that, like, you see 100 doctors for, and you just want to.
maybe Amy, you can also describe the difference between AI agents and AI that So is that what you're describing? Is that an AI agent that supports your work? What does that mean when you say you created?
Yeah, so I've just used ChatGPT and I've configured an agent to help me. And so, say for the neurologist, I read in all of my personal medical data that's relevant to it, and it involves genetic data and data from a whole bunch of different specialists, plus some family history. And then if I would get a new test result, I would ask it, what it thinks. But for me, I'm particularly interested in early recognition of symptoms and early diagnosis and early treatment to arrest any future, bad things that could happen as a result of some conditions that I'm at risk for. And what it recommended that I do, I've shared it with several of my physicians, and one of them afterwards said, after we talked about that, we had a grand rounds at Kaiser Permanente, and everything that you suggested, they just put out there as this is the cutting edge, this is a future direction of where this is going. And yes, we do actually have arrangements that we can do all these tests. So, I feel like I want to help people to do stuff like this for themselves. But
so
obviously,
I think we can, sorry, I didn't mean to interrupt
no,
you.
go ahead.
We can go to Stefano. Now, Stefano has the Carevocacy, and then you're integrating AI. You can describe what you're trying to do, and then from the discussion, how are you solving these problems? There are regulatory challenges, right? So at the same time, you probably want to move fast, efficiently, help as many people as you want, but at the same time, you want to be careful, right, how you do things. So if you can describe what you're doing, and
Yeah, I guess from a startup tech scene perspective, we would love to not have a lot of regulations, but I'll be honest with you, I think we should have more regulations around integrating artificial intelligence, especially when it comes to patient data. I think one of the challenges we're going to face is how it's going to affect HIPAA compliance and patient data, and how we should really craft policies around that. I was about to say, one of the things that I'm really interested in, specific to this question, and I'll share a little bit more about our work, I believe, in the second question, if you don't mind, Isaiah, but more so about creating sandboxes that are controlled, or more so areas where we can have some sort of, where it brings multiple partners from the community, whether it be institution, industry, researchers, to really understand how to develop an AI that helps underrepresented populations. And I think that's more so what I'm interested about and what I'm looking forward to see as we continue to look at more policies and regulation for AI. One of the things that I'm excited to be participating in, it's not necessarily I guess it is a sandbox, but it's an accelerator program. But we just recently accepted funding from the National Institute on Aging to develop an AI tool to help older adults when it comes to digital health literacy. And that's something that we're really excited about. And what I really love about this program is because we get to be mentored, partnered with researchers in this field who understand, AI, but more so public health experts to really understand and develop the AI tool. And so it's not only me, there are 19 other companies that were chosen out of the 200 that submitted. And so I'm really excited about that program and to share more about those details. But I think sandboxes and places like that should be more in the community when it comes to developing AI, especially when it comes to policies and healthcare information.
Thank you. So, Charlotte, that's for you being at the University of Maryland. And you have access to many schools, researchers, and researchers. How do you respond to this? We're thinking of Sarah and Stefano and Amy as practitioners, right? So that distinction is blurred now, but how do you take all this information and with the AI Institute we have at the university, if you can, yeah.
So what a lot of my colleagues and the researchers in these institutes, especially for Trails, because it's centered in AI governance and policy. Well, basically, these researchers are spending a lot of time training the policymakers. And so they are acting as advisors where they are bridging the information literacy gap that the policymakers have. And, they, like Amy was saying, to create a policy brief is one thing if that is your background, but if it's not your background, how are you supporting yourself in filling in those gaps? And so in our case, a lot of our policymakers that we have been engaging with are very excited about AI, and they want to be the first one to write the bill to get that across and be known as, such and such person. But there are some gaps that are missing, and a lot of it lies along the lines of that AI black box, not understanding the technology, not understanding the process that it takes to produce these conversational bots that we are using, such as ChatGPT, and understanding the whole loop of once you have taken data or collected data, trained the model with this data, it produces a particular output or response based off of the user's input or person's input. And now taking that all the way back around, like, where does this data go now? Where does it live? And so a lot of the questions that my panel members here have, and the curiosities and the wonderings and the fears that we all share, our policymakers have, but our role is to help them work through those questions by providing them the technical background, the research background that they may not have access to within their own, day-to-day crazy worlds, in order to make better informed decisions as they are creating policy for their constituents. And I want to add this other point here. One thing that in my personal experiences, one thing that a lot that is truly missing is this data collection part. When we're thinking about the healthcare system, from the time you walk into the emergency room, there is data being collected on that particular individual, all the way until if they're being omitted, if they have to stay admitted, if they have to stay there for a few days, constantly data is being collected on these individuals. Well, the healthcare system has their own data that represents many of the communities that those hospitals surround, right? when we start to bring in some of these commercialized AI systems into these healthcare settings, they are using data that comes from the internet. They are made foundationally off of ChatGPT or OpenAI's other products that they have. And we, as what healthcare providers need to also be aware of, is that whatever AI system that they bring in that is commercialized may not be the best tool to serve the population that they have. If you are in a rural community and a lot of the patients there are, they have their digital divide, so they're lacking access to certain things. They have particular parameters that they may be going through depending on where they are in the United States. And then you are using these data sources where here you have the US, and it's all these people who have contributed to this internet data, right? Well, how is it informing you about this rural community who doesn't have that same digital access, who hasn't had a chance to contribute to this data collection? So I caution healthcare providers about quickly adopting AI systems that are commercialized, that they can't get a chance to customize and have a say as to what data is being collected and used for their systems when they're thinking about their healthcare systems.
Thank you. So we'll open, we have about 12 minutes left for the panel. So our next question is like the trends that you're looking at, future trends and ethical innovation. I'm skipping one of the questions we had because it's about misinformation, and it was discussed in the earlier presentation. So something positive that you can share, encouraging, right? There's improvement. I can give you Sarah if you want to chime in.
Sure. I think what we are very excited about is mainly the convergence of AI, real-time social determinant of health collections, the data that we collect around what type of the support system every person receives, and edge computing. When you're collecting the data remotely, real time from the patients. So when you're combining all of these together, then you are going to working in a harmony to deliver care that is not only clinically effective, but also socially responsive. And also what we see in Horizon is the quantum computing, which promises to accelerate this decision-making process to milliseconds. So it's exciting. I think what is ahead of us is very exciting. I wanted to, grab everyone's attention. Close your eyes. Imagine a future that AI doesn't just diagnose a disease, but understand when a patient is likely to miss an appointment because of, housing instability or food insecurity or lack of access to transportations. And then automatically, that is the key, coordinate a community support. And this is not just an intervention, a clinical intervention, but actually taking it to the next level. So in-person clinic, we are already building towards that holistic approach, integrated AI-driven screening, community referrals, and virtual care. Those is already there, but we are taking it to the next level. And our focus is underserved population. So we are very hopeful for future, and especially echoing the patient voice. That is what I think is very, very critical for our society moving forward.
Thank you, Sarah. So we can give the participants some time to ask questions. Each of the panelists, what are the future trends? What do you see positive? Stefano, you can take, let's say, a minute or 50 seconds, let's
Yeah.
say.
Yeah, no, thank you for that question. I was just going to quickly change my virtual background because it's like a much more visual presentation. See how slick that was? Anyways, no, as I was sharing before, we are trying to do a lot of work in AI now and trying to deliver digital navigators at a more larger scale. And something that we're excited about working on is delivering digital navigators through our tool called Apple AI through SMS and text messaging. And it may not be able to serve every population, but we know that we've worked with a lot of older adults who just can't step out of the fear of just asking that one question to be curious about something. And if we can break that barrier of entry, I think we're really unlocking opportunities for digital health literacy or digital literacy in general. And so I'm pretty excited about that. And as I mentioned before, we're getting funded through the NIA through that to do more research on that tool. But I'm really excited about trends like that. I also was going to do a shout out to Amy. I don't know if you guys know this, but CMS cited one of her works. She's probably going to shake her head at me right now, but cited one of her works. And that's how we kind of connected, actually. But CMS did cite one of her works about the importance of digital literacy as being one of those major social determinants of health. And now CMS is requiring Medicare Advantage plans to provide some sort of digital health literacy solution to millions of Medicare Advantage patients, right? And so I think we are seeing policy changes slowly, but I do think that's an amazing feat for what's happening in digital equity and digital literacy. And then the third thing, I didn't mention this in my introduction, I'm a caregiver to my grandma who's living with Alzheimer's. And as much as I love support programs like the Alzheimer's Association, sometimes I'm not available to attend those meetings. So what do? I go to ChatGPT and I ask, what can I do? Or can it give me some sort of support as a caregiver myself, as especially navigating and identifying certain symptoms that my grandma's dealing with through her care of Alzheimer's. And so it's been a helpful tool as something that I'm really excited about, as it supports so many people, just answering some of the curious questions that they might have and giving them access to somebody that they might be able to have some sort of availability to. So yeah, that's what I'm really excited about when it comes to AI.
Thank you. So we'll go to Amy, and then Amy, if you can, less than a minute.
Sure, I'll be very fast. Not to be Debbie Downer on the technology, but I think that the need for human connection is not going away. But the big untapped resource that I think there is the home health aide population who, generally speaking, do not have digital skills, and they may not have smartphones. And my mom's home health aides are not allowed to even use their own phones for text messaging. But if we can break through that kind of stuff and train them and then bring in the AI, then we've just supercharged this workforce that hopefully we can also lift out of poverty by upskilling them.
Thank you. Naresh, you had your hand raised. We have 5 minutes left, so we want to give, there are some questions in the chat. Naresh, do you want to go pick one of those?
Yes. The first question I see here is, do 300 plus million US consumers have to learn and master AI and become the primary care doctor? That's question one.
What do you think, Sarah?
Would you repeat the question one more time? I want to make sure that I got it the way I got it.
Sure, absolutely. It's, do 300 plus million US consumers have to learn and master AI and become their primary care doctor?
The question is, they don't must, but I think they are doing it. So I always, I'm surrounded with the doctors, and I tell my doctor friends that your customer today might come to your office and knows in advance what they are dealing with. So are you prepared? Are you ahead of them? Whether I think this is something that one question that I think we skip it. It was about trust and misinformation. And Emmy, Sarah has elaborated on that in a great detail. Trust is we must gain trust based on the merits. And our mass population today, they don't have that trust to our health system anymore. The way that we used to bow to our doctor. He was the God, she was the God. But it's not that case anymore. I think the answer is not no, we don't need to. I think we should actually put the pressure on our health system to gain our trust again, 100%.
Thank you, Sarah. Anyone else wants to address the same question? 300+ million Americans. Do they need to master AI or? Amy, do you want to?
I was just going to say,
Stefano, go ahead,
as we've all mentioned here before, I think AI is a tool, not a perfect piece of tool. We should always use it cautiously. But I do think it is going to help people access information that they probably have never had. But I do think just with everything that this whole conference has been really pushing on, which is being very careful in accessing that information. So that's the only thing I would say about that. Sorry.
So we have 2 minutes left. So any final comments, recommendations, or any tools, resources you want to share?
There's a question in the chat about recommendations for AI translation.
Yeah, so that will be our closing question. Any recommendations for resources? I know this was really short, like it felt really short for me because we are dealing with really big questions. But if you can take, that's it, 20 seconds, you can say, these are the resources you can use. You can keep learning. Yeah. We start with the Amy and then Charlotte and then, yeah.
I'm going to pass because I don't have any great answers. I'm really kind of new diving in on the AI side of it.
Okay.
I may take that regarding the translation, because we do a lot of translation and still we use professional translators. But for the when there is a situation for personal use, we wanted to translate. What I do, I always suggest, so if, for instance, if you are translating from Chinese to English, make sure that you are when you're translating back again, get that English translated back again to Chinese. And of course, you know the Chinese and see if it comes the same way, it means the same way. I think that's, we call it reverse engineering. And that might help us to validate the AI translation engine, whether it's working really good or not. So especially, I think they are doing a better job. If you're using any translation engine, make sure that is specialized and customized for the field that you are using. If it's a medical paper, again, there are tools for medical translation. And if it's general, just do the reverse engineering and see if it comes the same way.
Thank you. Charlotte and Stefano, then we'll close.
I don't have anything to offer on translation. However, as far as things that I'm looking forward to, there are some AI agent builders that are in research right now that are exploring platforms for non-AI experts. And this kind of lies to the question about do 300,000 people or million people need to learn AI or master AI? sooner than we know it, it will be probably a block-based situation where people will be able to create their own AI agentic assistance, and without with very little technical knowledge, because it's already in research now.
Thank you.
It sounds like the extension should create a course on building
Yeah.
AI agents.
Yeah.
I was just gonna say, I was gonna make a joke and say just chat GPT that question, and and you'll probably know the answers, and it'll probably give you way better answers than we've been giving answers, just saying. But I do think there are definitely online courses and provided by institutions already out there when it comes to mastering artificial intelligence, from building something of your own. And I do want to say this, not to just like, if you don't come from a background of research or academia, like, it is very accessible to create your own AI right now. And I'm saying this from a person who comes from that background, right? And I envy my colleagues who are in that research, and they're having a deeper understanding of how this works. But if you're like a curious person who just wants to try it out and test it out, there are tools already out there to do it. But I put a little like precautionary tale, which is like, be careful, be cautious, and just be aware that these tools are still in the experimental phase. And I do agree with everybody that, you know, it is something that we all have to adapt to. But it is something you can use today. So it's don't be limited by your lack of experience or research. I encourage it, and that's what we encourage our. I had a class the other day where I was encouraging seniors on deep fake and image generation, not because I wanted them to do it, but because I wanted to let them know that it is possible for them to also participate in that, and that it is out there and it is real, and to be able to know that you can identify it. So anyways, that's I just want to say thank you again, Zayas, and everybody for bringing us all together.
Thank you,
for this
really.
panel.
Yeah. Thank you, everyone.
The Managing Director of Techstars AI Health Baltimore, powered by Johns Hopkins University and Care First Blue Cross Blue Shield. The mission of the Techstars AI Health Baltimore Accelerator is to empower AI healthcare startups to achieve rapid commercial traction through mentorship, resources, and network access, accelerating their path to market leadership and sustainable impact. Prior to joining Techstars, Nick co-founded, led, and sold Proteneus, a Baltimore-based AI company that brought automation and risk reduction to healthcare compliance. So I'll ask you guys if you can please turn on your cameras if you can, and feel free to interact with him as he is giving his speech. And please welcome our keynote speaker, Nick Culbertson, who will be discussing gaps in access and care.
Thank you so much, everyone. Really appreciate it. Thanks for having me here. It's a real honor to be here today. So as Marie said, my name is Nick Culbertson. I have the privilege of leading the Techstars AI Health Baltimore Accelerator. It's a program built on a powerful partnership between Techstars and the incredible minds at Johns Hopkins University and the community commitment of Care First Blue Cross Blue Shield. Just a little bit of background on myself. I started my career as an undergraduate at the Johns Hopkins University studying cellular molecular biology. Unfortunately, my father passed away when I was an undergraduate, so I joined the military to pay for school. While I was in the military, I served as a Special Forces Green Beret and Advanced Tactical Practitioner, and did 4 deployments over an 8-year period. I was fortunate to get out of the military in 2012 when I joined the Johns Hopkins University School of Medicine, with the goal of becoming a clinical and academic researcher. While I was in medical school, I started a research project with my now co-founder using artificial intelligence to study clinical, studying clinical pathways to optimize care outcomes. And we accidentally discovered fraud that was occurring into the medical records using artificial intelligence. And so we showed our research to hospital administrators, and they said, this research is cute, but we would actually pay for a solution that helps catch us fraud. And so we took the leap of faith and explored the market and actually launched a company called Proteneus that used artificial intelligence to catch various types of employee activities that put health systems and patients at risk. My co-founder and I scaled that business over a 10-year period, and actually grew it to about 30 million in revenue before we sold it just last December to a private equity-backed company. So it's quite an incredible journey. I learned a lot along the way and can attribute a lot of my success to the mentors and advisors that helped supported my business. But it was an incredible journey understanding how the healthcare system works and all of the challenges that healthcare systems face. So here in Baltimore and indeed across the nation, we stand at a pivotal moment in healthcare where we see unprecedented technological advancements, particularly in areas like artificial intelligence. Yet we simultaneously grapple with persistent, often widening gaps in the access to quality of care. Disparities tied to race, income, geography, and other social determinants remain stark realities. So the core question we must ask ourselves is this: how can we harness the power of innovation, not just to create healthcare tools, but to actively dismantle those barriers and build a truly equitable system? How do we ensure that the future of health technology serves everyone? So today I want to explore the future with you. And to do that, I want to talk about some of the technologies and companies that I'm working with in Techstars AI Health Baltimore. So before I do that, just a little bit of background on Techstars. Techstars is an accelerator program that operates on a franchise model where it partners with organizations like Care First and Johns Hopkins to set up accelerator programs to help startup founders find market traction and be prepared to fundraise from venture capitalists. Every accelerator program has different focuses, and the reason that the Baltimore ecosystem selected healthcare AI is because we truly believe, as Nuri said in our mission statement, we truly believe that AI has an opportunity to help accelerate the advancements of healthcare. The US is famous for having one of the most expensive healthcare systems in the world. And while healthcare expenditures outpace other well-established countries, we don't see better results. Life expectancy is lower in the US than other developed nations. But we also see blockers to access and care. Oftentimes people joke that AI is never going to replace clinical therapists or never going to replace what doctors do. But the reality is right now we don't have enough doctors or clinicians to treat clients or treat patients. And so if we're not even providing care for everyone, then that actually presents an opportunity for artificial intelligence to be a force multiplier to our clinical staff. And this is really relevant because many forecasts show that we have a shortage of doctors, nurses, therapists, pharmacists, et cetera, especially as the direction we are heading. So I would propose that while AI does have risk and concerns on a lot of front, it actually is a huge opportunity for healthcare, and especially when you think about technology. Those people in healthcare technology know that the tech in healthcare is probably 10, 15, maybe even 20 years behind other industries. And so sort of like developing countries advanced mobile technology faster than the US. The US had an established landline network and didn't need mobile technology as much in the 80s and 90s when it first emerged, where other countries embraced it really quickly because they didn't have a robust landline system. And so I think the analogy there is apt for healthcare, where healthcare has been very challenging technologically speaking because of all the barriers to building technology. You have access challenges, compliance, security, regulatory burdens, and then not to mention all the long sales cycles and the fine margins that health systems operate on to provide care. So what I'm positing here is that the expensive nature of our healthcare systems, the tight regulatory challenges and restrictions to access to care actually creates barriers to treatments. And the opportunity with artificial intelligence is to both address the economic burden to hospital systems and health systems by making more efficient workflows, actually increasing access to patient care. So as I said, Techstars is an accelerator that helps support companies. And so we're in the inaugural class. We're planning 6 classes over the next 3 years. And this first class has 8 stellar founder teams that have joined our, none of them from Baltimore, but all have moved to Baltimore for our program, and are building advanced technologies using artificial intelligence to address these different gaps in healthcare. I'll give a couple examples. I'll start with one similar to analogy I gave earlier. A company called Opal uses artificial intelligence to increase patient engagement between therapy sessions. So as I said earlier, we don't have enough therapists in the country to treat every single client that needs access to mental health. And one of the challenges is many clinicians are at a capacity when it comes to their client load. So what Opal does is it creates engagement between sessions to ensure that patients have continued treatment and continued access, and that allows therapists to actually increase their capacity, their client capacity, treating more patients. So it's a really effective tool that we find actually is a force multiplier for our clinicians and gives them the ability to treat more patients and spend more time with their patients and provide more care. So that's maybe a more direct example of that force multiplier effect of artificial intelligence. But there's lots of different ways that it can have an impact. And just another example I'd like to provide is a company called EmbryoExcite, which is a startup that's based in Argentina, out of Buenos Aires. Their solution is a really interesting one that addresses the efficacy of in vitro fertilization. So just a little bit of background on IVF. The best studies with the least amount of variables removed show that the likelihood of an embryo to be implanted in utero are 75%, which means the best we could achieve the success of having a baby through implantation is 3 out of 4. However, the average across all in vitro fertilization clinics is around 30%, which means most women pursuing in vitro fertilization have to go through several rounds of IVF therapy, which is painful. So again, I think the biggest bet I'm making is that AI can reduce the costs and increase access of care in healthcare. But more specifically, I think some of the regulatory and compliance burdens that prevent technologies from being used in technology, that's one area that I would make a bet on. And many of the technologies I look at when thinking about our accelerator or investment are very unsexy underbelly aspects of healthcare. Sometimes they may not even be direct care. Like when you think about AI in healthcare, you might think about scribes or ambient technologies that are helping clinicians interact with patients directly. But there's actually a ton of back office compliance and regulatory areas that increase the cost of healthcare and create burdens that could be alleviated through the use of artificial intelligence. Stefano, I think those were template questions. I'm not sure if anyone else has any other questions.
All right, final call. Does anyone have any last minute questions for Mr. Culbertson? All right. Well, thank you so much, Nick. That was a perfect way to round out our conference. We really appreciate you taking the time to be here with us today.
Yeah, of course. Thank you all.
All right. And before we wrap up, I know it's been a long day and I really do appreciate everyone for sticking around and being here with us. As we wrap up today's conference, I just want to take a minute to sincerely thank all of you, including our speakers and our panelists, and all of you that registered for taking your time out to be here, providing your expertise and your insights throughout the day. And a huge thank you to your engagement, your energy, and the commitment you have to advancing health access and technology. We hope today sparks some new ideas and connections that you'll carry forward in your working communities. Before we close out, I want to share a few quick reminders and upcoming items. So continue learning about the future of health and technology by joining us for the Empowering Health webinar series that's lasting from May 16th to June 27th. It is a weekly webinar that's only 1 hour from 11 a.m. to 12 p.m. You can register by scanning the QR code, and I'll hold this up here for a minute, but you can also find this on the Marylanders Online website as well. So I'll hold it here for a second. Oh, and Julie also put the QR code and the link to register in the chat. Thank you so much, Julie. You can also get in touch with Marylanders Online by going on our website, sending us an email, or contacting us at our tech helpline. We're open from Monday through Friday from 10 a.m. To 8 p.m. and Saturday from 10 a.m. to 5 p.m. Our program is on all social media, including Facebook, Instagram, LinkedIn, and we have a newsletter as well. I believe Julie is going to put our Linktree QR code in the chat as well, and you can also find it on our agenda for today. So if you'd like to stick around to network, we do have the opportunity for you to do so. We will keep the meeting open until 4 p.m. If you have any additional questions or any questions on how to contact certain speakers or panelists, we'd be happy to help you. And if you aren't staying to chat, please look out for a follow-up email from Marylanders Online, and please complete our conference survey, which you can find on this slide right here using this QR code, or in the email we'll send out, the follow-up email, which will probably come on Monday or Tuesday. So on that note, thank you again to everyone, because it's people like you who make these events so special. Wishing you all a wonderful rest of your day and weekend. Thank you all.